आपको भेज लो और मुझे दे दो। Yes, sir.
Hello, middle class.
आपको मुझे फोन कर दो। दे देना। The camera is here. Good morning, everyone. Respected teachers, seniors, and colleagues. Today we are going to have a small CME on hearing care. So basically, as you all are aware, World Hearing Day is held on 3rd March each year to raise awareness on how to prevent deafness and hearing loss and promote ear and hearing care across the world. The theme for 2023 is Ear and Hearing Care for All. Let's make it reality. This CME will highlight the importance of integrating ear and hearing care with primary care and general practice, and also provide tools for that integration or expansion of services. Hearing impairment continues to be one of the most prevalent and chronic disabilities that we are experiencing here, affecting over millions of people in the world, and majority of such individuals are children and over the age of 65. Despite of this prevalence in society, hearing loss carries an age-old stigma. It is regarded as a hallmark of infirmity, senility, mental and communicative incompetence, and social asceticism. The hearing aid has conventionally been viewed as a symbol of that stigma. Many of the causes that lead to hearing loss can be avoided through public health strategies and clinical interventions implemented across the life course. In children, nearly 60% of hearing loss is curable. Likewise, in adults, most common causes of hearing loss, such as exposure to loud sounds and ototoxic medicines, are very, very easily preventable. Certain clinical conditions are completely reversible and curable if picked up and treated on time. At Sir H.N. Reliance Foundation Hospital, our goal is to bridge this gap and provide world-class healthcare by setting up seamless care for such patients and provide hearing care for all. Let's help with the timely intervention to get the patient care to the next level. I really appreciate you all taking time out on Sunday morning to attend today's CME. Let's begin with the next talk, which Priya is going to give. I'll invite Priya and let her sister. She's our audiologist, senior audiologist. Unfortunately, just couple of changes. Dr. Tarang couldn't come for the inauguration thing. So Dr. Mohita Chandra, our medical director, she would be reaching soon to inaugurate the ceremony. Dr. Nishit Shah is not able to come as he's not well today. And thirdly, Latika Prabhu, she's another audiologist along with Priya. So she's not able to make it as she's unwell. So these are the three little changes that we are going to have in the sort of our list of panelists and the speakers. Priya's talk is ready. Was there any problem? Yeah, so we're waiting for a couple of minutes. The talk was supposed to be only on one laptop and there's some glitch with that. They're trying to sort that out. Bear with us for a couple of minutes and we'll Okay. So you want to announce Dr. Nelishi, can you come in, please? Meanwhile, Priya's PPTs are sorted. We can start with examination of ear and anatomy of the ear, please. Dr. Nelishi and Dr. Vinay.
Good morning, respected teachers, seniors, and my dear colleagues. Today we'll be talking on the anatomy of ear and examination of ear. Coming to the anatomy of ear, we should know that ear is the organ of hearing. It plays an important role in maintaining the balance of the body. The ear is basically divided into three parts, as we can see here in this image: the external ear, the middle ear, and the internal ear. So coming to the external ear basically consists of three parts, which include the pinna or auricle, as seen in this image, the external auditory canal, and the tympanic membrane. So we'll be talking a little in detail about each of these. So the auricle and pinna, the entire pinna, except its lobule and the external auditory canal, are made up of a framework of a single piece of elastic cartilage, which is covered with skin, which is seen in this image. So there's no cartilage between the tragus and the crus of helix, and this is called the incisura terminalis. And the pinna also consists of the lobule, which is made up of fibrofatty tissue covered with skin. The auricular cartilage is continuous with the cartilage of the external auditory canal. This image shows the various elevations and depressions on the lateral surface of the pinna. Like you can see the helix, the antihelix, the concha, triangular fossa, sympa concha, the crus of the helix, tragus, antitragus, and the lobule. Now I'll be talking about the external auditory canal, which measures 24 millimeters along its posterior wall, and it extends from the bottom of the concha to the tympanic membrane. It is not a straight tube, it is S-shaped. The outer 1/3 is directed upwards, backwards, and medially, and the inner part is directed downwards, forwards, and medially. Therefore, when we want to see the tympanic membrane, the pinna has to be pulled upwards, backwards, and laterally, so the tube becomes straight and we can have a clear image of the tympanic membrane. The canal is basically divided into two parts, the cartilaginous and the bony. So in this image, we can see the cartilaginous part of the canal and the bony part, which is the inner 2/3. The cartilaginous part forms the outer 1/3 of the canal, which is 8 millimeters long. It is continuation of the cartilage of the pinna. The skin covering the cartilaginous canal contains ceruminous and the pilosebaceous glands, which secrete wax. And hair is confined only to the outer canal. Therefore, furuncles are seen only in the outer 1/3 of the canal. Now coming to the bony part of the canal, which forms the inner 2/3 or 16 millimeters. It is devoid of hair and ceruminous glands. 6 millimeters lateral to the tympanic membrane, the bony meatus presents a narrowing called isthmus. So foreign bodies which are lost medial to the isthmus get impacted and are difficult to remove. Now we'll come to the third part of the external ear, which is the tympanic membrane, as seen in this image. It forms a partition between the external auditory canal and the middle ear. It is oval in shape and it measures 9 to 10 millimeters tall, 8 to 9 millimeters wide, and it is 0.1 millimeter in thickness. It is obliquely set, making an angle of 55 degrees with the floor of the external auditory canal. Therefore, the posterior superior part is more lateral than the anterior-inferior part, and it is divided into two parts, the pars tensa, which is the majority of the tympanic membrane, and the pars flaccida, which makes the small upper part. The pars tensa forms most of the tympanic membrane. Its periphery is thickened to form a fibrocartilaginous ring called the annulus, which fits in the tympanic sulcus. The central part is tented inwards at the level of the tip of malleus, which is called umbo, and a bright cone of light can be seen in the anterior-inferior quadrant. The smaller part is the pars flaccida, which is situated above the lateral process of malleus, between the notch of rivulus and the anterior and posterior malleus folds. Now we'll be coming to the second part of the ear, which is the middle ear. The middle ear, the middle ear together with the eustachian tube, the adytus, attic, antrum, and mastoid is called the middle ear cleft, which is lined by mucous membrane and it is filled with air. The middle ear is divided into three parts, the mesotympanum, the epitympanum above, and the hypotympanum below. It consists of 6 walls, the medial, the lateral, anterior, posterior, and the roof and floor. The tympanic membrane is semi-transparent and it forms a window into the middle ear. From the tympanic membrane, it is possible to see some structures of the middle ear, like the long process of the incus, the incudostoperial joint, and the round window. Seen here. The middle ear consists of 3 ossicles, which are the malleus, incus, and stapes. So these ossicles are very important as they conduct sound energy from the tympanic membrane to the oval window and then into the inner ear fluid. 2 muscles are also present in the middle ear, which are very important. The tensor tympani, which tenses the tympanic membrane, and the stapedius, which helps to dampen very loud sounds, thus preventing noise trauma to the inner ear. So here we can see the 3 bones of the middle ear, the malleus, the incus, and the stapes. And this is the tympanic membrane. Coming to the third part, the inner ear, which is very important because it is the organ of hearing and balance. It consists of the bony and the membranous labyrinth. The bony labyrinth consists of 3 parts, which is the vestibule, the semicircular canals, and the cochlea. The vestibule is the central chamber of the labyrinth, which has the oval window lying in its lateral wall. And we have 3 semicircular canals, the superior, the posterior, and the lateral, and the cochlea, which makes 2.5 to 2.75 turns around the central pyramid called the modiolus. Also, membranous labyrinth is very important, which consists of the cochlear duct, the saccule, the utricle, the 3 semicircular ducts, and the endolymphatic duct and sac. So basically, we'll talk about the physiology of hearing in brief. So when a sound signal from the environment is collected by the pinna, it passes through the external auditory canal and strikes the tympanic membrane. The vibrations of the tympanic membrane are transmitted to the stapes footplate through the chain of ossicles coupled to the tympanic membrane. The movement of the stapes footplate causes pressure changes in the labyrinthine fluid, which moves the basilar membrane, and which in turn stimulates the hair cells of the organ of Corti. These hair cells act as transducers and convert the mechanical energy into electrical impulses, which travel along the auditory nerve. So basically, the mechanism of hearing is divided into the 3 parts: the mechanical conduction of sound, the transduction of mechanical energy to electrical impulses, and the conduction of electrical impulses to the brain. Thank you. Now I'll be handing over to Dr. Vinay, who will be talking about examination of the ear.
Good morning. I'll start the examination of ear. The examination of ear begins with Starting with examination of pinna, you look for size of the pinna, presence of congenital anomaly, perichondritis and low set ears. Like size of the pinna, if you look at the image down here, it's a you see it's a microtia. It's also known as the peanut ear. Because of the embryological anomaly, the size of the pinna is merely reduced to the size of a peanut. If you look at this ear, this is the cauliflower ear, also called as pugilistic or boxer's ear. One who are engaged in a profession where they have to face blunt trauma to the ear, especially the rugby players, the wrestlers, they land up in this condition. The cartilage is dependent on the skin for nutrition. And when there is a fluid collection taking place between the cartilage and the skin, the cartilage gives away, and this is the appearance that when the cartilage gets. There's some of the common conditions also seen, like anosmia, there's complete absence of pinna. There's a bat ear, as the name suggests, outwardly projecting ears. There's a lop ear, the hyperflaccid helix, and the upper part is almost covers. Microtia, as I've already discussed. Cup ear is also like the embryological anomaly in which the helix and upper part of the pinna makes a shape of a cup. Cryptotia is the buried ear. The ear is normal, but it is buried beneath the skin, requires further surgery to correct it out. Now we move ahead to examination of preauricular region. Some of the most common findings what we see in a preauricular region is the presence of a preauricular sinus. As you can see here, there is a small pus point from an opening in front of the helix. So this often gets infected, requiring excision of the tract. Second is preauricular appendages, what you see here. These are some of the findings they need to take care of. Now we move into examination of post-auricular region. Look for scar of previous surgery, very easily seen. Look for swelling of mastoiditis. As you can see, this child has swelling in the post-auricular region. The pinna is pushed downwards and forward. Look for any fistula infected, making away from skin to the mastoid bone, needs further surgery for correction. And obviously presence of lymph nodes, which may be indicators of infection or malignancy. Now we move ahead to examination of external auditory canal. As Dr. Nilishi explained, the canal is not straight. It's almost S-shaped. The pinna has to be pulled upwards and backwards in adult to straighten it up. In children, pinna is pulled downwards and backwards. We examine the external auditory canal for numerous things. The most obvious one is the wax, which you can see it here. Discharge, is there any discharge present in the external auditory canal? Otomycosis or any foreign body. If we further look for some of the common conditions that we can make out, like exostosis, they are the bony outgrowths. So better felt than seen, keratosis obturans, swelling or edema, or atresia or stenosis. Now we move ahead to examination of tympanic membrane. This is how the normal tympanic membrane looks. We can divide it into four quadrants: anterior, posterior, superior, inferior. You need to divide the tympanic membrane in 4 quadrants. Look for the handle of Miller. This is what it is. The normal landmarks, the cone of light that projecting anterior inferiorly. You can, if possible, look for the presence of incudostapedial joint and also watch for mobility of tympanic membrane. If you go into further detailed evaluation of tympanic membrane, do look at the color of tympanic membrane, whether it is congested, whether it is normal, pearly white in color, or see for the presence of hemotympanum. Depends on which condition it has undertaken. Presence of perforation, a small perforation, we can show that patient has a tubertympanic disease in the past or atypical disease. Presence of polyp or granulations, a retraction pocket, such which you can see here. Thank you.
So I would like to welcome Dr. Mohita Chandra, our medical director at Sir H.N. Reliance Foundation Hospital, to address the. Please, ma'am.
So very good morning to all of you. It's really wonderful to see all of you here, and I don't know how many people are online. On behalf of Dr. Tarang Gyanchandani, I welcome you all. She could not make it because of an exigency, but it's an honor for me to be standing here to welcome you all on this very important day, which is the World Hearing Day. And this is celebrated just as an awareness for all, because hearing, as we all understand, is a part of integral communication, which affects our social and emotional well-being as well. At Reliance Foundation Hospital, we have a state-of-the-art department or a cluster where we have all diagnostic and therapeutic modalities. It is supported very well with the operation theater, with all microscopes for all microvascular surgeries. All this is of no importance till we have a great team. So we have the best team with us for all innovative solutions for hearing health. And I would really appreciate and and honor the team that we have here. We also have an outreach program to address to all the hearing health issues and create awareness. So I would not take too much of the time because I know there's a lot of speakers waiting and a lot of exciting debates which are going to happen today. But I would just say that blindness separates us from things, but deafness separates us from people. So with this, I think you all can carry on. Thank you very much.
Thank you. Thank you so much for your short and sweet address, ma'am. I have received a short message from Dr. Kanti Patel, who's one of our senior most colleague from the department. Unfortunately, he couldn't attend the CME because he is in United States right now. He sent a small message, which I would like to read out to you all. Dear Smita, I would like to welcome and greet delegates and wish success of CME, for which you've worked hard and I appreciate. This message will take 2 to 3 minutes and it will glorify us. Respected CEO Dr. Tarang, my dear colleagues and delegates and friends, my warm welcome to you all at Sir H.N. Reliance Foundation Hospital, which is pride of our nation because of our founder, President Mrs. Neeta Ambani, whose passion is respect for life and unconditional support of Chairperson Mr. Anant Ambani. Dr. Tarang is backbone of this remarkable success of the institution, and because of her leadership and transplant surgeons cooperation, 6 organ transplants we have performed in last 24 hours in this hospital last week, which is remarkable. I know my highly experienced colleagues will deliver recent advances in ENT, which will be of great help to delegates. Despite my sincere desire to participate actively in this CME, I regret my inability to attend because of current situation here. It's my privilege and pride as a senior honorary ENT consultant at this hospital. I wish great success for the CME. With this, we will start with the panel discussion. May I please call upon our esteemed panelist. So basically, we here at Sir H.N. Reliance Foundation Hospital, we are all trained otologists and are lucky to have a good team of otologists here. Otologists are the ones who deal with the ear surgeries and ear conditions. So I would like to invite upon them one by one. They are all not only good clinicians, but excellent academicians and amazing teachers. Can I please call upon, starting with alphabets, Dr. Anagha? Dr. Bachi? Dr. Jyoti Tabholkar, ma'am? Dr. Prabodh Karnik, sir? Dr. Vicky Khattar? So this is what we are here at Sir H.N. Reliance Foundation Hospital ENT department. We are blessed to have a good team of clinicians working with us, and let's start with the panel discussion today. So this panel discussion is mainly sort of aimed at making people aware of common clinical conditions that we encounter in day-to-day practice and how to deal with them and what are the different options that we have available for the same.
Disturbing the
First
I'll,
slide.
I'll minimize this. इसको minimum कर दीजिए ना।
ये तो पैनलिस्ट के पास जाएगा ना।
आपके पास
Yeah, yeah. Yeah, has to hand over this. So let's start with phase one. Basically, I would like So this is our case number one, presentation one. 5-year-old child presented to ENT OPD with complaints of mouth breathing, snoring, decreased hearing, intermittent episodes of upper respiratory tract infections which are happening on and off since last 1 year. How would you investigate this patient would be my question to Dr. Anasa.
Good morning, everyone, and thank you for the wonderful session that we are having here. This is the classical presentation of a child with adenoid hypertrophy. So what you have is a child presenting with mouth breathing, snoring, hearing, and apart from these symptoms, you would see that the patient would be having classical adenoid phases. Now this happens because normally, if your whatever part of your organ, if you're not using, that atrophies. The same situation happens if you're not breathing through your nose and the patient is breathing through your mouth, then actually the appearance of the face changes. So the nose becomes pinched, the palate becomes high arched, patient has a very flat face, the mandible is recurred. So these are the classical adenoid faces that the patients have. And so on examination of, you cannot see the adenoid, they can be visualized only on an X-ray nasopharynx. So if you do that, you will see an enlarged adenoid and blocking of the nasopharyngeal air passage. Also, these patients can have serous otitis media. That is, what happens is that because the eustachian tube is blocked, a negative pressure gets created within the middle ear because the eustachian tube normally equalizes the atmospheric pressure with the middle ear. So now if the eustachian tube is blocked, the negative pressure in the middle ear sucks in the fluid from the cells, and that causes a serious collection of fluid within the middle ear. That gives the patient decreased hearing, and you would classically see fluid behind the eardrum. Now in this case, there are air bubbles also. So this actually suggests that the eustachian tube is recovering. So the patient might recover from that serous otitis media. So what you would see in complete serous otitis media, there is a serous straw-colored fluid behind the eardrum, and the eardrum is a bunching of it. So in such cases, when you do X-ray, you have an X-ray? Okay, when you do an X-ray, you see the bulging or soft tissue bulge on the nasopharyngeal wall, and these patients would be, you would advise the patients to undergo adenoidectomy with pylopotomy with glomet insertion. So adenoidectomy will clear the nasopharyngeal passage, will decrease the mouth breathing, and will prevent the adenoid cases from happening. Because what happens is the patient also can have crowded teeth, and dental architecture is disturbed.
Just to go back to your first slide. Just to add, this patient is definitely a 5-year-old, so one can contemplate surgery. If child was under the age of 5 years, like 3 or 4 years, you have to conserve this. So probably you may do only adenoidectomy, do a myringotomy. You will wait for 1 or 10 days of antibiotics and decongestants and everything. But you might have to do adenoidectomy and clear the ear and give the hearing back to the patient, and probably you will have to wait for some more time. Because 5 years is a cutoff. 5 years you can do the tonsil adenoid, but under the age of 5 years you cannot do this. For the tonsil and adenoid, you can do the draining of the fluid or maybe insertion of the bromine or something. That can be done.
Okay, so basically, point taken in this particular case would be this, in terms of hearing. This child probably is suffering from a hearing loss which gets undetected multiple times. Parents are not even aware of the fact that child is not able to hear correctly or not able to localize the sound correctly. Lot of times it happens that mother says, I call you up to multiple times, it is not being attentive. More than not only able to hear, it becomes more like an emotional situation that is not being attentive, is not giving answers when I'm asking it. So I would like to urge everyone that when there is age, that particular age group, when there is clear-cut history of multiple upper respiratory tract infections, there is possibility of hidden hearing loss there, which is from the secretory otitis media, which probably gets unattended to, and getting it addressed on time by getting simple audiogram done. If child is cooperative, we do pure tone audiogram wherein the graphical presentation of hearing is obtained. If at all child is not attentive, we go ahead with the behavioral hearing audiogram. Medical management, as probably you said correctly, is adenoidectomy in long run, but
For the recurrent infections, you may have to give antihistaminics, antibiotics, and sometimes you may need to give nasal decongestant also. Just to add to what Dr. Smita rightly said, that you have to be attentive to the patient's and give attention to the fact that the patient is not hearing. Why it so happens that it gets neglected because they don't present with hearing, nor do they present with any autoria. So which clearly indicate that there is some ear infection or ear problem happening. So they are not like adults who complain of decreased hearing. So it's just that the non-attention and that is why it gets neglected.
so basically this particular fluid becomes more like a hidden handicap for that child, right? So how long can we allow that fluid to be there? Can I ask Dr. Gagnon, please? How long can you allow that fluid to be there?
So in my book, secretory otitis media is a medical condition first. Do remember we are ENT physicians first and then ENT surgeons. If you do have issues that you have amplified and talked about, the first thing that you need to do is to begin medical treatment. Antibiotics is the mainstay. Need be, you should give antihistamines, nasal steroids, or whatever it is. They say 6 weeks of hearing loss, apparently between the age of 2 and 5, is supposed to cause permanent damage to language acquisition, to intelligence. In my book, I think I extended a bit. I would even wait for about 2 months, 2.5 months, till the parents are convinced that this patient needs some action. And the action before that would be, in addition to using medical treatment, I for one give or suggest people to use something called AutoVent, which is a wonderful device which you get it off the Amazon, where you can just, instead of teaching them how to do a Valsalva's maneuver, if you go to autovent.com, it will tell you how to use it. If you blow a balloon, air goes inside. And there are often situations where you can avoid surgery. But if surgery has to be done, I would wait for a minimum period of 2 months before you do bromide insertion. If at all I do bromide insertion, often I would do it only on one side and do only a myringotomy on the other side, aspirate. Because bromide insertions, there's that do have their own problems. I mean, these are surgical nuances which everybody will have different ways of doing.
As per international standards, they say we can wait up to 10 to 12 weeks, which is very much close to what Sir said. So around 10 to 12 weeks, we can continue to observe these children. However, if this particular clinical condition, the fluid doesn't drain beyond 12 weeks of time, that's when we consider bromide insertion. And
Also,
bromide
little bit of a school advice that says these children should not be the last benchers. They can wait to sit in the front row.
Right.
And little bit attention to them, because in conductive deafness, you raise your voice and patient can hear.
Absolutely.
So the problem is little bit at home also, till you wait for all this time. And my personal observation is that the myringotomies are done much more abroad than in India. I mean, we have allergy, and now that we were just discussing about the dust allergy, which everybody is suffering and coughing. We have allergy, but we don't see so much of a pollen allergy as the Western world sees. So the myringotomies are much more commoner there. And even probably school must be intervening that this child is not hearing or something, but in India, it is normally neglected. And the rate of myringotomy is much less than what the Western
True,
world
I totally agree with you, ma'am, that there is lack of awareness in our country about this clinical condition. Probably because of the coexisting situations, as madam said, environmental factors. However, early intervention at school is a very important thing that we are lacking in India. Abroad, they don't let kids start attending school before audiograms are done and the impedances are carried out. So, lot of kids are screened at that age. And exactly keeping in same line, I would like to also add that the rate of myringotomy and bromide insertions are very minimal in India. However, rate of tympanoplasties and tympanomastoids are more in our country. We hardly get to see that over there. This itself suggests that doing this at a particular age avoids them having those situations later in their life. Okay, let's move on to the, by the way, this is how the typical grommet looks like. It is a ventilating tube which actually allows the media to ventilate and function better. Let's move to the next slide, which is the, right. So, this is 3-year-old child. Thank you so much. This is 3-year-old male child. What
is.
What is the difference between pure tone audiometry and regular audiogram? It's a general thing.
It's same thing, it's same. So normal audiogram is
pure tone audiogram. So pure tone audiogram is the correct word, PPA, but some people are just using word audiogram. So audio means listening and gram is like a testing. So it's like a chart kind of a reading you get by plotting at each frequency, by giving the sound to the person in a soundproof room, and you test each frequency and at what frequency his threshold is detected, that is graphed, and when it is complete for a right and the left ear with the masking, that chart is called audiogram. But the whole process is called pure tone audiogram.
So we are going to have a complete session on audiological evaluation. All these doubts will be clarified during that. We will conduct that soon. Okay, so going back to the next question. 3-year-old male child was brought in ENT OPD by parents as the child was unable to speak. Parents also complained of unresponsiveness of the child when called by name at menu. Always, actually, that is wrong. Always. Occasionally responding and most of the times not responding. This warranted further evaluation of 3-year-old male child. Dr. Bachi, can I please have you on the questions on this? How would you like to evaluate this child?
Thank you, Smita, and welcome to all our delegates. Now, many a times, this child will not come to an ENT consultant first. It will always, parents will always take this kid to one of you, that is the family physician, and ask for opinion that the child is still not speaking, the child is speaking very less, the child responds sometimes. In fact, just yesterday, one of my friends who is a doctor called me up saying that my sister's son, who is 2-year-old, he speaks very less, and actually, I think he has a slight hearing problem. When I asked him, he said, every time we talk to him, he responds sometimes, but many times he does not. Now, what happens is that when the child does not respond, parents or relatives try to make some action by means of which the child understands. Like you want to drink water and you tell, like this, the child knows, yeah, I need water. or come to eat food, chalo khana khane aa jao. So the child understands the actions, but the child is actually not hearing. A child will always repeat what he hears. If he does not hear, he cannot speak. It's as simple as that. The first thing that we need to do as consultants, as physicians, is to get a hearing tested. If the child is around 1.5 year old, the child is supposed to speak at least 2 syllables, mama, dada. If he is not speaking, it is understood that he cannot hear what he is being told. Many a times when we talk to the child, "Yo, mama bolo, papa bolo," the child does not respond at all. Something falls down, the child does not respond at all. But you clap your hands in front of the child responds because he's seeing. He cannot hear. You know? So many a times it is thought that the child cannot speak, but the child cannot speak because he cannot hear, he cannot repeat what you are speaking, and he cannot get the language. So the first thing that you need to do is get a hearing test done. The hearing test that we do in a small child is either play audiometry or audiologist Dr. Priya will explain to you what we need to do for children who are very small. But it is possible to screen a child even when the child is born to know whether the child can hear well or not. And nowadays, most of the hospitals, including ours, has a newborn screening program in place which helps to detect these children and follow up these kids. So once you follow up, you know that this is a child who definitely cannot hear. The next thing, after knowing that the child has got a profound sensory hearing loss, which is in both the ears, is to find out the cause. So one of the causes would be that there is a problem in the inner ear. And we need to evaluate the child, we need to think of surgical intervention or something by means of which the child can start hearing and start speaking as early as possible, because the speech center, the hearing center in our brain eventually will atrophy by the age of 5. It is ideal if we can pick these children up before the age of 5, maybe in the age group of around 1 to 2 years, and intervene so that they can start speaking and be a normal learner. If the child is given good hearing by way of maybe a high-end hearing aid or by means of a surgical intervention such as cochlear implantation, which we do regularly in our institution over here, the child can go into mainstream, any of the mainstream fields. Like we have a child whom we have operated who is today an engineer. So you can imagine the impact that can have a child who would be probably a disabled person when he grows up if he is not intervened in time. So eventually go into a mainstream of life and have a normal, as good as normal life.
Right. Thank you so much for that insight. Dr. Vicky, could I please ask you next question? What are the important points that need to be addressed at the time of counseling of the parents of such patients whom you're considering cochlear implant?
So the biggest challenge we face practically is the denial factor. And I think most of us have had this problem in our daily practices. The fact that the parents will say that, hum bhi late bole the, hum bhi late chale the, and that denial factor actually makes us lose a good 2 or 3 years of solid, time where the child can be amplified by whatever means. That's the first thing which we have to make them understand that, the very fact that you got your child at this stage, which means it's definitely a hearing loss. I think the universal screening program which Dr. Machi mentioned has been quite a game changer, at least in the major cities where it's been forcefully implemented and rightfully so. And most children who do not pass the OE, or the Acoustic Emission screening at the time of birth, have to be mandatorily screened at the age of 2 to 3 months, or sometimes even before discharge. This is a prolonged NICU stay, basically. Especially the kids who have kernicterus, ones who have newer jaundice, those kind of children, who require to have these 3 screenings mandatory before they get cleared for hearing into society. That's the first challenge most of us face. Now, what happens is once the children, the family comes to us, the next challenge is that they want everything on a fast track mode. And that's where the next problem lies, because things cannot be fast track once you're diagnosed with hearing loss. From the first instance of a documented hearing loss, the child needs to be amplified and given a hearing aid trial, even if the child has profound hearing loss. Reason being twofold. One, that if the child has any small amount of residual hearing, the auditory cortex in the brain has to have that continuous stimulation. Otherwise, like what Dr. Bachi said, the windows of speech development in the brain, I think they begin closing at the age of 2, 5, and eventually at 8, everything goes completely down. So early intervention, and that's why even if the child is profoundly hearing loss, we think the child is probably going to require a surgical cochlear implant at some point of time. Even then, the child needs to be put onto a hearing aid for at least 6 to 12 weeks. The second advantage of putting a hearing aid is that the child is habituated to using a machine, because eventually if the child does require a cochlear implant, that the external abutment of the implant is very similar towards the standard hearing aid. So that habituation also comes as the child understands that this is something which is good for me because they are unable to communicate and they are unable to understand what is good for them. So that's the second thing which we enforce them to do are on a board footing. Then of course, you go on to, like Apache said, investigation to understand whether there's any cause. So about 85 to 90% of them are idiopathic, which means there's no cause, but about 10% you do pick up certain syndromes which need to be addressed medically, and that's where the role of a pediatrician and a developmental pediatrician especially will be very, very paramount to making sure that the medical factors which could probably confound a surgical intervention should be taken care of in the parallel time when you are fitting a child with a hearing aid. So usually what happens is you expect by the time the child comes to you at the very first consult, to the time 3 or 4 months down the line, you have resolved all medical and other issues to make sure the child gets ready for a surgical intervention if required. At the end of 2 or 3 months, I think Priya also will elaborate this, is that we do what is called an aided audiometry to see whether the child's aided thresholds, by which I mean what the child hears with the hearing aid, they fall within a certain category called a speech banana, which is the tracing present on all standard audiograms. And if the child's amplification or amplified hearing threshold or child benefits the hearing aid to the extent that if all the frequencies, not some but all, or at least most of them fall within that speech banana, Priya, you'll be able to show that to us, right? Then the child can hold on for a surgical intervention and then it doesn't become a medical emergency, so to say, or surgical emergency. The next stage, of course, would be to get imaging done. So you get a CT scan and an MRI both, because the CT scan is it's the gold standard to ascertain abnormalities of the bony labyrinth, and which is the inner part of the ear, which is in the bone. And the MRI is, of course, to trace the entire neural pathway from the time it begins at the cochlea and ends up at the auditory cortex. So these mandatory investigations will be done all at the same time. So once the child comes to you with a hearing loss, which is suspected to be a congenital, profound, or a severe or profound hearing loss, all these things need to be put into action at the same time, so that you have a kind of chartered, structured program with the name challenges for the surgeon.
So we also follow this tracker which we prepared, right? So basically, this is to give us a guideline to make sure that the child is getting prepared for surgery. We know once, of course, we've evaluated rest of the things and child is a candidate for cochlear implant, then that child has to go through these particular tests to be able to get tick in front of each section so that the child proceeds towards the clearance for the surgery. Jyoti, I was going to ask.
Just to summarize the whole thing.
Yeah.
I think any general practitioner getting a parent telling that my child is not speaking as he should be speaking at about 1 year of age, and probably some hearing difficulty. I think that child needs to be referred to and specialist ENT who can completely assess the child and intervene early. Basically, at 1 year is a cutoff. Because even cochlear implant done earlier has a better outcome than when it is done after 5 years of age. In fact, some of the government schemes don't permit the child is about the 5 years, because by then the brain plasticity is lost and the benefit of such an expensive. Because Vicky, I think, did not mention it is about 7 to 8 lakhs. So even parents have to generate that fund. That will take too much of time, or probably leave that to whoever is doing has to generate the funds from the government schemes or whatever. So that will going to take time. So all this adds to the delay. So if you start off early at about 1 year latest, then the process can be finished within a year or whatever, and child can be fitted with the implant at the appropriate age when he gets the maximum benefit. So this is crucial, that the person who is contacted first should not waste the time and refer the child to the specialist.
Thank you, ma'am, for that. That was my question to you. Anyways, you answered it. So now next question is to Karnik sir. What should parents expect in the post-op period for patients who undergo cochlear implant surgery? And can you please throw some light on the switch-on appointment for the?
Number one, I think don't expect it to. There's a lot of work that needs to be done on part of the parents, on part of the patient, on part of the physicians, on part of the audiologists, and the entire team that does those stuff.
Very true.
So you probably should count the day of surgery as day zero of speech. And then expect maybe 1.5, 2 years later where the child starts speaking a few words and start picking up things. Every child would be different. Every environment is different. Speaking to the child more often, doing appropriate amount of mapping and doing appropriate amount of so-called tuning the implants are very important. Insofar as switch on is concerned, I think the switch on is probably done about 3 weeks at least after the operation is done, so that the healing of the post-oral wound and healing of the whole surgery has occurred. You can probably do it a little earlier, but 3 weeks is good enough time. And perhaps take home messages, I think everybody has said what they're supposed to. I think very little more.
Dr. Anatha, would you like to add any point that has been missed out from this discussion that you would like to actually make it one of this?
No, I don't think we've wonderfully covered by all the panelists. I think everyone has reiterated, and the fact needs to be reiterated, the surgery is a minuscule part of the whole thing. And what follows, the programming, the right environment, the right adaptation of the child is the most crucial thing. So parents have to be prepared mentally for that after post-surgical programming of the implant and the frequent visits to the hospital and to the audiologist that has to be enforced upon the and has to be, sorry, speech therapy, yeah, programming and speech therapy, yes.
So auditory verbal therapy. All right, point taken. This is how typical cochlear implant looks like. Dr. Bachi, would you like to just?
So we have two parts. One is the receiver, which is implanted in the patient during the surgery. So this is a receiver which we implant in the patient during the surgery. I think Dr. Priya will elaborate further and she will actually show you how it looks during our talk. And we have 2 electrodes. Some of these implants have only 1 electrode. So this is the ground electrode, and this is the one which helps in hearing. This goes within the cochlea. As you can see, it is slightly tall. We introduce this through the round window membrane into the part of the cochlea known as the scala tympani. And this is kept inside the patient. We close the wound, and this is the outer, the processor that is placed outside. But this is placed after almost 3 weeks, as Dr. Karthik just elaborated, 3 to 4 weeks. Once all the tissues are healed, then this portion is placed outside on the patient's scalp. It holds in position with a magnet. And this magnet is a little strong. So if you implant or if you use this slightly earlier, maybe say after 2 weeks of surgery, or if the tissues are not healed well, it can form a stoma and cause pain to the patient. So this we wait until all tissues are healed, scar formation has taken place, the scar is strong enough to hold the magnet well in position. And most importantly, I would like to add over here is that the patients need to be explained, the parents or the relatives, that the child, this is not a transistor. The moment you put it on and you switch it on, what is the use? I have spent so much. They are very dejected, very upset, very fast. They expect results with the click of a finger, not possible. It takes a very long time to get the child rehabilitated into a normal speech and a normal hearing volume. But if you implant the child, we have implanted children who are around 1 or 1.5 year olds. These kids do not require much speech therapy or auditory verbal therapy because they recover like how a normal child would recover. When you train them at home, you say this, you say that, and the child automatically starts hearing at the correct age. So the earlier you implant, the better are the results.
Thank you so much, Dr. Bachi. So, yeah. Yes,
Just to add a small anecdote, when we started doing implants in hospital starting 2014 and the team of anesthesiologists was very new. The very first time we did the implant, watching myself, and the anesthetist was getting the child out of anesthesia and said, "Chalo, utho." So I said, "Child can't implant ho gaya." So the fact of switch on, the concept switch on was so new at that point in time because Because you grow with your own teams, and then we will understand this is just the machine which is being placed inside. It's going to take a few weeks for switch on to happen. So switch on is basically the time when the external apartment is put and the machine is actually switched on. And so
Also, expectation is there, even with some doctors I have seen that they're not aware of the fact that cochlear implant has got external device to it. They feel everything should go inside and nothing should be seen and child should be hearing immediately. So these are 3-4 important points that we all should be aware of the fact that when
Basically, it should be all counseling and it should be videographed. When you do the counseling to the parents, it should be videographed because these are the points which leads to frustration and medical intercom.
exactly, very good point.
And I think it should be documented that all this was explained and it is not like a surprise or something.
So let's move on to the next one now. So I've got a 49-year-old male after taking long flight from USA to India, walks into my OPD and says that since last night, since I have actually landed, I've got sudden onset pain in my ear. My ear feels very heavy, and since then I feel my hearing is gone. Okay, so Dr. Ananda, can you please enlighten us as to how should we proceed here on?
Yeah, so this is, because the air travel is becoming more common and more frequent, I think you also would be encountering a lot of patients with this kind of symptoms. So what the patient has had is, typically the patient may have had an episode of URTR, may have had cold before his flight, or sometimes what does happen is that the patient is asleep during the flight and he has not equalized the air pressure changes that have occurred during the flight. The patient experiences barotrauma. This typically occurs during the ascent or the descent of the flight. So more often the descent, but it can happen also during the ascent. So so what we expect is that when we see the patient, he gives the history, and when you see the otoscopic examination, you will find a very congested drum. It can be either retracted, as you can see here, and there could be some amount of hemorrhage or hematoma that you see within the middle ear. So one aspect is prevention, and the other prevention for the next flight, that what precautions he has to undertake, and the treatment of this. So treatment of this, generally it does not require antibiotics to treat the middle ear problem, but it may require antibiotics for this upper respiratory tract infection that he has had. And it will need nasal decongestant in the form of xylometazoline or oxymetazoline nose drops, and anti-inflammatory drugs to decongest the eustachian tube orifice and for the inflammation of the eustachian tube, antihistaminics, and additional is the antibiotics. You also advise the patient to take steam inhalation. So that will sort of be like a mucolytic for the thick mucus that could be blocking the eustachian tube opening. And the treatment modality, that is the main thing that we would advise, is to give preventive measures or teach the patient how would we prevent this from happening again. So one is that if he is having a URTI before the onset of the travel, he has to treat that by taking decongestant and antihistaminics and treat the upper respiratory tract infection. The second thing, even if it does not have cold, what you have to advise the patient is that if he has allergic kind of a tendency, you need to ask him to take antihistaminics 2 to 3 hours before his flight. He can also use nasal decongestants before the flight. Especially, you have to advise the patient not sleep during the flight, especially during ascent or descent. Because what happens is that when we are awake, it is only that time that you are swallowing. And with swallowing and with the jaw movements, the eustachian tube opens up and equalizes the pressure. So if you are sleeping, especially during the ascent or descent, your eustachian tube opening will not happen and the equalization of pressure will not happen. So the patient should not sleep during the ascent or descent. He has to keep chewing something, or he has to have some mint or maybe chewing gum or something, so that he is using those lozenges and the eustachian tube remains patent and equalizes the pressure. Also, if he feels that there is a block, he can be advised to a Valsalva maneuver or whatever it takes to open the eustachian tube, either a jaw opening or a yawn. This can open up the eustachian tube and equalize the pressure. And if he experiences decreased hearing, in spite of doing all this, after he lands, he may need to consult a physician or an ENT surgeon, ENT physician for that.
Right. Jyoti ma'am, how long do you think such kind of case takes to recover or to get back to normalcy?
It depends on the severity. If it was mild, that was just feeling blocked and all that, take decongestant sprays, Valsalva, maybe for pain something, and it generally resolves. But if it is very severe, then there was excruciating pain, and the orthoscopic findings are what you showed that there was an average also. It is not going to resolve very fast. It is going to take any 8 to 10 days. But it is not something which is serious if the discharge has not really started. It will come around. Maybe in some situation you may have to do a steroid spray so that the eustachian opening happens early. But this is a typical barotrauma, so it will resolve.
So,
8 to 10 days is the time. If it goes beyond, and if the hearing loss persists, then he has to have audiogram.
so would you do audiogram in all the patients or would you select few patients?
No, there is no point doing audiogram in an initial phase. We have to counsel the patient that since the drum is completely withdrawn inside and there's a negative radial pressure, maybe a little bit of a fluid or whatever, you just resolve with this and you will be all right. But basically opening of the eustachian to aim, like Valsalva, steam inhalation, steroids, oximetrazole, all those will open up the eustachian tube. So it is basically going to take some time. Right? So 4 to 5, maximum 8 days. If the symptoms persist beyond this of a hearing loss, then he may need to see for audiogram.
So, Karni sir, would you agree with the fact that audiogram needs to be done only on selected cases or do you feel that it should be done in all the patients?
Agree. I think not necessary to do it in all patients, but there will be some patients who have nerve deafness also. Especially the some patients who have, patients with blockage of the ear, has had a cold, the virus has gone inside, some amount of nerve deafness has occurred. You might suspect, especially when there's a little bit of dizziness. And these are the patients who would then need systemic steroids in a reasonably high dose, the usual kind of 1 milligram, 2 milligram body weight, along with an antiviral, along with an antibiotic. And then it's worth documenting, but otherwise, only if the patient does not improve after a reasonable period of time, which is about 10 to 14 days, you could do audiometry and then decide how to treat. Insofar as the treatment modalities for recurrent barotrauma, I think especially for patients who are frequent flyers or pilots or stewardesses or patients who love to go scuba diving now. I mean, there's a significant number of people who go scuba diving. These are the patients who must have their noses looked in. If there's a nose issue which is causing a problem, that needs to be attended either surgically or medically or done whatever. And you also need to be doing eustachian tuboplasty. I mean, eustachian tuboplasties are meant for these kinds of patients. Instead of putting bromeds, wherein these patients won't be able to swim, doing a eustachian tuboplasty like an angioplasty is worth doing, helps.
Right. So basically, just to Dr. Vicky, you have any other view on that? Would you like to say
I
that?
think just to simplify, a simple bedside chewing fork test will let you know which patient requires an automatic, it doesn't require an automatic. I think we've got some chewing forks today, but an obvious nerve hearing loss can be picked up on a chewing fork test if done correctly. And I think that can sometimes be a kind of screening process, whether which one's going to urgent automatically versus which one may not require at all in the first place. So I think that's something which, and all of us are so happy to doing that. It's very easy to screen it out.
Weber's lateralizing to the affected ear is a very reassuring sign that you will have. That is not a sensory hearing loss that you are dealing with.
And the reverse test can pick up to 4% of difference in two sides, which is such a sensitive test. It looks like a simple thing, but it's very sensitive.
Dr. Bachi? Okay. I would like to just add one little sort of point here or like to share small experience here. I have had this experience with one patient where even I thought it would have been just a conductive loss looking at the otoscopic examination. However, as an instant, I got the audiogram done, and to my surprise, it was better and everything was quite all right. But there was sensory neural hearing loss, minimal sensory neural hearing loss, which was detected on one side after flight, and unfortunate event, but however, we had that patient's pre-operative hearing test as a record because of the normal executive health check screening that happens in the hospital. So we could compare to that there and then, and we realized that he's developed a little bit of a sensory neural hearing loss. We put him on steroid, then he recovered completely. So whatever that 15 decibels he had lost. So I have started getting audiograms done in each and every patient's after that experience, thinking that I may not miss out on that opportunity. Maybe it's a little overkill, but yeah. All right. So we'll go to the next case now. So we finished with the safe rider, right? So okay. Yeah. So 26-year-old female from corporate sector came to ENT OPD with complaints of progressive hearing loss, which presented in both ears since last 5 years, which actually worsened with her pregnancy recently. There is no history of any fever, no history of cough, no history of cold or any associated ear infections. There is positive family history from her mother's side of decreased hearing in that patient's noted. So my question to you, sir, Dr. Kane, would be how would you take this patient ahead?
So clinical examination is a must. Asking for how long the hearing loss has been, number one. Has there been any evidence of tinnitus or noises in the ear? Has this come up after pregnancy? It has. Ladies are more common. And most likely, if I examine this patient, I would find near normal or normal intact hearing, intact tympanic membranes which are mobile. The Renes test would show bone conduction more than the air conduction, and Weber would go to the side which has more conductive hearing loss. So a classical intact drum, mobile conductive hearing loss. I mean, a mobile intact drum with a conductive hearing loss would show autosclerosis. And autosclerosis is a genetic condition. It's a genetic condition very often coming from the parents, from the family. Sometimes it is sporadic. And it shows up with progressive hearing loss. And the biggest giveaway is where the patient speaks in a very soft voice. In the clinic, you're almost diagnosing these patients because they are very, very sensitive. They become very sensitive and they have extremely soft voice. And there is a peculiar condition known as paraacusis bilesi, wherein they hear better in noisy situations, while others with hearing loss don't hear better in noisy situations. So in a restaurant or in an airport or a railway station, they actually hear better. And there are reasons for it which are different. But this is probably the classical situation for autosclerosis.
Absolutely right. So how would you investigate this patient and take that patient ahead?
So I'm still very old school. I mean, once I have done this thing, I would do a pure tone audiometry. I do an impedance if available, and impedance is not diagnosing autosclerosis as much as confirming autosclerosis. A mobility of the eardrum is probably more important. And I think to me, that is really enough. There are people who do a lot of radiology for autosclerosis. I'm not so sure it helps. I'm still very old school in that. I don't do MRIs and CT scans to confirm or diagnose autosclerosis. And to my mind, surgery, which is probably one of the mainstays of treatment of autosclerosis, does not need CT scanning or MRI. To my mind, this patient just needs to be counseled regarding treatment, which is often either the use of hearing aid, which is non-operative, or doing surgery. I mean, very often I tell them, if you are in the Himalayas, you don't need any surgery or hearing aid. But if you're staying with a family, you're staying in Mumbai, you want to hear, you figure it out what you want. Whether you want surgery or whether you want a hearing aid is something the patients can make their informed choice.
Dr. Bashi, would you like to add any more sort of investigations? Do you want to put some more light on?
Not investigations, but just one thing that we need to keep in mind is that if the patient of otosclerosis coming with these complaints also says that I am hearing a certain sound in my ear, and on examination with the otoscope, you see that the eardrum appears to be slightly pinkish, not exactly translucent, a pinkish hue on the eardrum, it would indicate that there is an active process going on. And in such a case, at least I would defer surgery for some time, waiting for the process to get complete. So otospongiasis is active otosclerosis, when we do not really wish to operate because there is more amount of bleeding and there is a chance of hearing loss worsening during surgery. You wait until the process is absolutely fine and it is the end stage, that is the otosclerosis has set in, only then will you go in for a staphyloctomy, or of course, as Dr. Karnik said, these patients benefit 100% with the use of a hearing aid. So it is the duty of the consultant to explain to the patient that you have two choices, either hearing aid or surgery. Of course, most patients who are young, usually this is seen in the younger age group, would prefer surgery and not a hearing aid at this stage in their lives. But eventually, after a period of maybe 10, 15, 20 years, this patient will require a hearing aid despite surgery. That is what we have seen over the years.
Dr. Ananya, would you do, sir has already pointed out about the CT scan as such. Do you get CT scan done for all your patients for with osteoporosis or?
It's as Dr. Karnik sir mentioned that CT scan is not a must. But what we have seen is that first, it doesn't add to the diagnosis, but when you find an otosclerotic focus, it really confirms your diagnosis and very reassuring. Second thing is that you do the CT scan to avoid any surprises during surgery. Like if you have a very large internal aortic meatus or a superior semicircular canal disease where that may be acting as a third window and your surgery may not actually improve the hearing. Or you may have a very overhanging patient nerve which will prevent you from accessing the foot plate or persistent stapedial artery. So, or maybe temporal sclerosis which is causing ossicular fixation. So all these surprises can be avoided when you have done a CT scan. And in fact, I would like to mention that it was given as a thesis topic to one of my students, and we have had the CT scans corroborate the findings corroborating with the intraoperative findings, and we have had situations where we were sort of prepared to avoid the complications in such cases.
Sir, what are the complications that we get to see during surgery as a surgeon, and what are the common challenges that we face, and how does it actually come out as an outcome during post-op period, and what are the steps to be taken to avoid or to help such situations?
So stapedotomy, according to me, is one of the most gratifying surgeries in ENT. You get near instantaneous results. In fact, you can make a career out of treating hearing loss because of otosclerosis. Patients will bring you other patients. It's probably the most gratifying thing to do. Having said that, there are lots of troubles in the way. Lots of troubles. And I think it's unnecessary to really brief the non-operating surgeon towards that. But I would always tell a patient that never will I promise 100% result. I would think that in my book, out of 100 patients I operate, 95 will be extremely happy. 2 or 3 I would leave them at the same level. One might go down a little bit, and one I may lose hearing. I mean, in my life, I think I can remember 2 patients I have lost hearing. I mean, fairly early after the hearing loss, after the operation. But otherwise, it's an extremely successful extremely good operation, has stood the test of time. The first tracheotomy was done in the late 50s by John Shea. So there's nothing new about this operation except the new instrumentation, the new microscopes and fancy old things, fancy new things that they're doing. Otherwise, an extremely successful operation to do.
Thank you so much for that, sir. Dr. Jyoti ma'am, would you please give us some information on the medical management of the autosclerosis that some surgeons
So I would
consider?
say this was my thesis topic in 79. Epidectomy was my thesis topic in 79.
Yeah.
So.
Can you please tell us about that?
As Bharti said, that some patient you may pick up the squad sign, where you see there is a reddish hue on the behind the tubular membrane. If that is the case, then it is an acute process and you should wait. You should not be hurrying of surgery. The treatment is given as medical treatment by to enhance the calcification or making this process little faster. So autoflow is a treatment and you give that in 20 milligram BD one morning and evening. And these patients may complain to you with the tinnitus and tinnitus, and that's a bad sign. You should not be operating immediately when the patient has a tinnitus. Give autoflow and then wait for at least 3 to 4 months. Do periodic audiograms. If there's a worsening, like if there's a sensory neural element setting in because of the process, then you should not operate this patient. Tinnitus should not be there when you operate because patient wants the tinnitus to go and generally surgery may not take away the tinnitus, and tinnitus is a bad omen sign that patient may worsen, like how you said. Because there's a cochlear element and any procedure you do, the cochlear element may take away your all efforts to improve the hearing. So medical management of treatment is not there in all patients. If the patient is complaining to you during the pregnancy, patient has to wait for at least 1 year after the pregnancy. This patient can be put on a sodium chloride. And it should not be excessive also because fluorosis will cause the dental problems in this patient. So generally medical line of treatment is for cochlear involvement or active tinnitus or active process going on. You must give sodium chloride. If the patient wanting to wait and think, you can put the patient on sodium chloride. But waiting too long for surgery, again this cochlear element will set in and patient may lose the chance of getting a full recovery of the surgery finding. So counseling has to be, you can wait for some time, but not too long, like in years. And periodic audiogram to prove that patient is not going worse. So periodic audiogram every 3-4 months. Yes, in this patient will help clinician also to see which way is going.
So that would act more like a prognostic tool.
Yes,
for
and
us
also
to take clinical decision in terms of whether to surgically intervene or to continue to wait. It's a very well message taken.
And I personally think that hearing aid is an answer if the patient is absolutely no for surgery. But we as a clinician should say that this surgery is one which can be improved by the surgery and you can avoid the hearing aid. And earlier better, we should try doing it early.
Thank you, ma'am. Dr. Vicky, will you please tell me your experience in terms of surgery versus medical versus the hearing aid? What kind of a preferences patients are what kind of a preference they go for, or how do they choose their option? Have you had encountered such kind of changes?
Because there is no medical treatment to cure this condition.
Of course.
The medical treatment is out. It is only in a select group. So either hearing aid or a surgery.
True.
So I think it's a very valid point because the demographic of the patient is sometimes a game changer. One, you have a young female who just typically presents in third, fourth decade of life. If they haven't completed their family, if they're planning to have family in the near future and see in the near future, one, you would hold on.
Right.
Okay. Second, if you are doing the surgery way before they're planning of a child, then also give them the option of the cesarean section because we had cases of baby getting lost with increased pressure also. That's second. Third is that the occupation of the patient. Dr. Mashima again, my patient was a boxer, the female boxer, and she said that I would want to go surgery. And we said, don't do it. Because what's going to happen is that you're going to have so much of strenuous exercises and she can't really hold on for a few months after surgery. So people who have a lot of weight lifting, we had a gym trainer once who came to us, we had a boxer. We have those kind of people who have a lot of, we are a professional scuba diver, just to, give those kind of typical scenarios where you would say that don't offer surgery at the very outset. Let them be happy with the hearing aid because you know that you can give them a permanent hearing loss, which is more detrimental than the existing loss which you have in the first place. Third, I mean, fourth, of course, is older people, above the age of 60, very wary of doing these surgeries because the chances of a permanent dural hearing loss are extremely high in the age group above 55. In fact, that's what the world teacher said, but now I think they push to 60, which is, they say, relative contraindications for staphylotomy as a planned surgery. So this is one part which you have to be very careful about as choosing the patient. And I would say sometimes putting your foot down as a doctor. When the patient comes to you for surgery, you say, no, I don't think it's the right treatment for you because you can actually come, worse with that. What is the second part of your question? One was
So basically, I was wanting to know that how do people prioritize their options? So for example, there are few people who actually demand that, no, I don't want surgery, I don't want hearing aid, but I want to try only medication because there was some fed information from somewhere, or they come up with that kind of a mindset that I want to have this option from you. So how do you actually deal with such situations?
let them on it. Let them on the surgery. First thing is, motor flow is only going to push that focus from an active to inactive focus. It's not going to change the course of the disease. It's only going to expedite that burnt out phase of motor sclerosis where the lesion which is in the ear becomes dormant enough to be surgically operated. That much rite of passage you will avoid. Second, let them take the hearing aid trial. It's just simpler for you. But once they've tried the non-surgical option, and if they filter out and say, we're happy with this, when and good, they go out as having said, let them take a call. Once they've taken the hearing aid trial and they say, no, doc, this is not working for me, that's when they already are tending towards surgery. So that rite of passage, I mean, I would never, of course, surgery, I mean, of course, I would propose, but I would never insist on the very first consult. I say, take some time. In fact, when they go for their automatically, I say, you want schedule a hearing aid trial, at least do it in the office. If you want to take a home-based trial, and a good 20% patients will drop out from the surgical program, which is absolutely acceptable. You don't want to have a patient who's coming with a half-hearted decision in the mind for surgery. And if they undergo the rite of passage and they come and 3 months say, no, I'm ready for surgery now, that you got them on the same page as you. So that's one filtration process, which I think most of us, exercise during the course of our preoperative evaluation. And one more thing about post-operative care, because what happens is that I think this counseling is extremely vital to make them understand that results also depend on the post-surgical care. It's not just a surgical technique and a surgical expertise, which is of course equally important. But after surgery, if they go to be reckless with their physical exertions and stuff like that, it becomes a problem. Even flyers, there's a lot of controversy about people flying back after CV surgical care. International patients come to us with the same. So I mean that's a way to counsel them. You got to be mandatory. Be in the city for at least 2 to 3 weeks. If you're flying out only for 5 to 3 weeks, but that's also cutting it really close sometimes, but I think sometimes logistics won't permit beyond that, and then of course you prime their nose, you give them enough decongestants, you let them know how to, the do's and don'ts for a flight. The second thing is of course, exertion after surgery, at least 3 months, no basic exertion. That should be something.
Do you also advise them not to fly for a certain period of time?
Ideally 3 months, because any surgery is 3 months.
The seal takes about, the Weber's transfer turn in about 3 weeks. Usually if it's a recently done surgery with a not a very deep fenestrum with a good seal, and 3 weeks you get a turn. And that once that turn takes place, of course it has to stay that way also. Longer the better.
So basically, this is how typically a piston look like. So this is the third ossicle which gets replaced with this Kaplan piston. And sir, would you like to make some concluding remarks about, because that has been your vast experience on stages. Would you like to make some concluding remarks before we go to the next phase?
So number one, demographics very important, especially in Mumbai. One tends to see a lot of Gujarati patients or South Indians or Kashmiri patients or Saraswats. That's number one. Typically, most patients choose surgery, especially so far I am concerned, because they're probably refused or not wanting hearing aids or taken hearing aids trials. That's number two. Number three, obviously, do only 1 year. And very often I tell them, look, the other year I wouldn't think of doing before 1 more year has elapsed. And most patients now are not coming back. I would think maybe 4 or 5 out of 10 patients that I do don't want the other year. Or often now I'm doing my second year, which I've done 20, 25, 30 years back. And I mean, insofar as age is concerned, I don't hold the bar of 50 or 60. I mean, my oldest patient has been 80. In fact, I must tell you, this was a patient whom I did somewhere in the 90s. She was a, poor burqa-clad woman from Mumbai, was thrown out by her family because she couldn't hear. They said we've been deceived by the ladies, this thing, by the lady's family. And she had autosclerosis. I gave her hearing back. And this lady fortunately did well. 25 years later, she came back with a senior lady in tow. And typically asked me, "Pehchana kya hai?" I said, "No." And she said, "Look, I am so and so whom you operated at that time. And my husband died 3 years after the surgery. I raised up 2 children by doing tailoring. I did everything at home. And my one son is in America, one daughter is married everywhere. And this is my mother, whom I am now convincing for surgery. And this mother was 78 years old. Mother wanted surgery at that time and had tried hearing aids, was not getting enough benefit. And happily I operated. Happily I operated. So this, according to me, is one of the most gratifying surgeries to do. One of the things which is really good to do and gives you marvelous results. No question.
Yes, Prashant, and one thing is this absolute contraindication, I would say, for doing the staphylotomy is the only hearing ear. If the other side has a sensory due to hearing loss, then you would always opt to give a hearing aid for that ear, the affected ear. So never do it on an only hearing ear, because there's always a 0.01% chance of you getting a sensory hearing loss.
Yes, absolutely. And one little point before we conclude on this case, when person is around 55, 60, that age group where they're possibly going to head on towards presbycusis with positive family history and not a big conductive component. What I meant by big conductive component is when nerve has also started getting weak in addition to the autosclerotic focus, where there is bare minimal gap. And that's where also we may not actually advise it, because probably they may require hearing aid very soon. So let's go to the next case. So 18-year-old female came to ENT OPD with an on and off ear discharge in the right ear with decreased hearing. So Dr. Jyoti ma'am, please can you tell us how to go ahead with this kind of
So basically, when you say just the history that the discharge with the hearing loss, the first diagnosis which comes to your mind is otitis media. Now, whether it is chronic or it is first time and acute, and all depends on how long back it happened. We did not say that how long back she is suffering. So probably any discharge with a hearing loss, generally we can presume it is CSOM, but not always true. If patient has a fungal mass in the ear, she will have a discharge and also conductive hearing loss because of that huge mass sitting in the ear. In wax, you will not have a discharge. So, you demarcate the external auditory canal reasons to give a conductive loss and give a discharge. So by and large, pharyngeal can give discharge and hearing loss, but there will be excruciating pain, fever and all that. So basically, it's by like what is associated symptoms are there with the patient will go on excluding the patients, but the causes. But the point I'm saying is if it is purely continuous discharge and a hearing loss happening generally and not an acute with pain and fever and everything, generally it points towards chronic suppurative otitis media with perforation.
So what are the otoscopic findings in a patient of ear discharge that you typically would see, and how do you proceed with such patients in terms of their
Basically, this
management?
patient will require a very good oral toilet. You take the patient nicely with a microscope or a good headlight and suck out each and every part of the discharge from the ear so that you can completely visualize the findings. And typically, if it is a CSOM, you will, at the end of every cleaning and everything, probably you will see a perforation. And that's a handle of radius, which is like a long bone. And then below that is a big perforation. And you can also see a bony joint, ossicular joint behind that nail there, which is a nucleus capillary joint. And probably a white sclerotic patch, which could be a typical sclerotic patch exactly happening there. So the typical finding will be a loss of timpanic membrane, which is a very transparent grayish kind of a membrane. And if you ask the patient to do the Valsalva, probably it will move with the Valsalva, but in the perforation, since the available drum is very little, you cannot see that movement. But probably you will see air bubbles and in the discharge if you make the patient do Valsalva. So kindly, basically it's a loss of the tympanic membrane. Depending upon the loss, you will see whether it is small central, large central, total, subtotal. The subtotal is where even the remaining part of that drum will be gone, and you will see a nice large perforation. And if it is total, then you will straight away see the annulus and not see any part of the drum. So anterior, inferior perforation, posterior perforation, subtotal, total is depending on how much tympanic membrane is lost.
So how would you proceed with the management?
So basically, if there was a discharge, you need to give a course of antibiotics, oral toilet, which you already done, safe, non-toxic ear drops like which causes ototoxicity should be avoided, like a gentamicin, but a Ciprox ear drops, decongestant tablets to open up the station to Valsalva maybe, nasal drops to if there's a massive allergy, you might have to have a fluticasone spray also. All that will aid at controlling this infection faster, opening up the tissue and probably prepare you for going ahead with a surgical line of treatment which will have to take to repair this eardrum. So eventually it will be surgical, but you have to optimize the patient to have a better outcome on surgery by doing all this what I mentioned and wait till the ear becomes dry.
Right, okay. So Dr. Anagha, how long will you wait before you take up such patient for surgery?
Yeah, so if the patient, generally patient has to be, should not have autoria for at least 2 to 3 weeks before you take up the patient for surgery. But having said that, there are situations where you do n number of things to make the patient, to make the ear dry, give antibiotics, give nasal decongestant, antihistamines, everything. Still the patient keeps coming you with discharge, you do ear toileting, that also gets the eardrops to reach into the media. But in such situations where you have faced a lot of difficulty in getting the ear dry, you may think of adding a cortical mastectomy to the tympanoplasty to achieve the anticoagulant patency and to prevent further problems.
Dr. Bachi, to you next. Would you please tell us what is the post-operative care for patients who undergo stympanoplasty or tympanomastectomy for that matter?
So the post-operative care is very routine, like how you would undergo for any other surgery, because you have a post-oral wound or you have a wound just in front of the ear, which would be a few stitches. Once we remove the sutures, we ask the patient to take care that you do not scrub that area very vigorously while having a bath. Water should not go into the ear because we place this absorbable foam inside the ear, which is called gel foam. So it's basically an absorbable cellulose sponge which is placed inside the ear and it is medicated. So once that comes off on its own, it will slowly and steadily come off. The eardrum heals very well by that time. So it is a protective foam that we place inside the ear. We ask the patient not to remove it. It appears to be reddish in color, so patients may feel there is bleeding. We counsel them that the ear should be covered with a sterile cotton at all times, at least for the next 3 weeks. Yeah. Once the healing takes place and approximately 3 to 4 weeks later, the ear is absolutely fine. If we have done something called mastectomy, where we have lowered the canal wall, the posterior canal wall, there will be a huge cavity. And we also ask the patient to take care that there is no water that goes inside the cavity, or while having a bath, they put a ear plug most of the times I ask these patients to buy those earplugs that they use for swelling. You know, so they just put those watertight earplugs, have a hair wash and then remove them off. But otherwise, the care is not really so much except that there should be no sneezing, there should be no spraying as much as possible. Because every pressure that is there is transferred to our eustachian tube into our middle ear and that could displace the graft, which is very fresh.
Anyone of you would like to add anything on the symptomoplasty question before we go ahead, sir? You want to add anything?
Not much. I think the most important thing, of course, is to differentiate between safe and unsafe population. Presumably, you were talking about unsafe populations. I mean, a safe population, number one. And not doing anything is always an option. Again, patients should choose. If they want hearing, if they want discharge, there are some people at the age of 60, 70, they have minimal discharge for a couple of years, hardly 20 dB hearing loss, not doing something, not letting water into the ears, intermittent suction, or patients who are on dialysis, or patients who got huge cardiac issues, or whatever. Not just having a choice. I mean, their choice, they don't want to do something. Not doing something in a safe population is a viable option, while not doing something in an unsafe population may not be a viable.
Absolutely. So also you have any experience with people who have got several perforations or any kind of a, let it be small or medium size or whatever, and having sensory neural hearing loss, wherein you end up requesting them to go ahead with hearing aid use by their choice and not getting operated and getting it repaired beforehand. What is your take on that, sir?
Yeah, you're right. I mean, if a patient is discharging, has significant hearing loss, nerve or bone or whatever it is, and wants hearing, now you've got to close the eardrum and give them an air conducting aid so that they can wear a hearing aid more comfortably. A bone conducting aid is never comfortable. As soon as you use an earpiece inside, this patient can get discharged more frequently and can drop the earpiece. So you are offering so-called tympanoplasty with a proviso that there will not be any improvement in hearing, but you're doing it only to close the eardrum so that good hearing aid wearing can be done.
Absolutely. So thank you so much for that. Any other point anyone would like to add? We go to the next one. Thank you.
So for the benefit of all the refugees, then I don't think there's any case you're showing for about the unsafety. You're not
That
showing.
was only because.
No, so just that's completed to their attending to ear surgery. So basically unsafe here is a kind of an emergency, not be tomorrow, walk up, CT scan, extent of the tumor, counseling the patient that this can lead to complication. You must be able to enumerate all the complications which can happen, like meningitis, brain abscess, post-oral fistula and abscess, facial now paralysis, hearing loss, complete or conducting, SN also can happen. All these complications you have to narrate to the patient, work up the patient, CT scan is a must, and not wait too much like how you can wait in a safe year, and take the patient up to make him safe by doing tubular mastectomy and osteoplasty to restore whatever hearing he can restore. And this is to be done with a little bit of urgency. So the surgical intervention in unsafe hearing is much more like in an emergency, not tomorrow, but in an emergency, and also with the proper counseling of the patient and workup of the patient. All other workup will remain the same, audiometry and CT scan.
All right. Thank you so much, ma'am. So let's move on to the next case. So the next case is a 52-year-old diabetic male came to ENT OPD with complaints of sudden hearing loss on the right side since last night. That's the history. Would you like to treat this as emergency, Dr. Vicky, in this situation? And if yes, why?
So sudden hearing loss is always an emergency. Yeah. And of course, audiometry is a mandatory to understand what kind of hearing loss is. I mean, they are not mentioning sudden, so we are assuming it's going to be a neural type of hearing loss. I think that's what we're discussing at this point of time. So sudden neural hearing loss is always an emergency, and I think timely intervention is the only way to ensure that you can get the best outcomes. Having said that, some patients do recover spontaneously, but you can't leave that to chance. The best time to intervene is, of course, within the first 40 to 72 hours, which is the golden time to intervene. But of course, sometimes patients don't reach the diagnostic level at that point of time. The literature says the first 7 days, best chance of recovery, 7 to 14 days, moderate chances of recovery. After 14 days, unpredictable chances of recovery. Now, I think your patient is also diabetic, so that also poses a little challenge to us because the mainstay of treatment, in fact, it's monotherapy with steroids. The role of antivirals is still controversial, though most of us still do give it. But I think steroids is the only treatment, it's like a Bell's palsy, it's a mononeuritis. The same goes for the auditory nerve, it's a mononeuritis. But with diabetic patients, if they are reasonably well controlled or in a controlled environment, you can still consider oral or even intravenous steroids. If titration facilities for sugars are not available, then intratympanic steroid injections can also be the next best thing. Although world literature still tends towards systemic steroids as the gold standard for treatment and should be given if possible.
Okay. How would you like to investigate this patient, Dr. Ananda? So the most important diagnostic factor is your suspicion of the sudden SNSL, and second is your in-house, like the Reniers and Weber said, that the tuning fork test that you do. The audiogram will corroborate or will confirm that, but mind you, sometimes if it is an experienced audiologist who is doing the audiogram and a proper masking is not done. What I mean is that patient has severe or complete SNHL or hearing loss on one side and absolutely normal hearing on the other side. So when you're doing an audiogram, if you're doing a sound for the right ear, which is dead ear, the left ear, the non-participating ear, hears the sound and it will give a false impression of a normal, false negative test. So your tuning fork tests are very important. Second thing, after doing an audiogram, you have to immediately start the patient on therapeutic measures. As Dr. Vicky rightly said, you have to put the patient on steroids. If the patient is diabetic, you have to titrate the dose of his anti-diabetic medications and give the steroid. Either it advisable would be in the injectable form, or if the patient is coming a little later or maybe not willing for admission, you always give oral steroids. You can do, as Dr. Vicky said, you can give intratympanic along with your oral steroids, or you can give intratympanic as in cases refractory to your intravenous steroid or oral steroid therapy. The other things you would like to investigate or you will always want to do is, in all cases of unilateral sensitivity hearing loss, you will always want to do an MRI imaging of the brain to look for cause of hearing loss. So most of the sudden sensitive hearing losses are because of autoimmune viral neuritis, but you would want to rule out anything which is going on in the brain, as in a compression in the CP angle or any lesion in the CP angle compressing on the nerve. So it has to be done. It may not be immediately within the next day, but you will always want to do that once your intravenous steroid or oral steroid therapy is over with. And investigations, right? Yeah, you would also do the routine investigations to know any comorbidities that the patient is having. And later on, I do always also do, if I don't find any reason for the loss of hearing, I also do certain autoimmune investigation for autoimmune disorders like C-ANCA, P-ANCA, and ANCA, and other tests in consultation with a rheumatology specialist. And along with the steroid, I also give antivirals, as Dr. Vicky mentioned, and you would also want to give antibiotic therapy just to take care of any bacterial labyrinthitis that is going on.
So one point which I want to make is diabetics, the moment you give steroid, the sugars are going to go up.
Yes.
And if you give a dose and give a full dose of 80 milligram, admit the patient, put the patient on insulin, do the monitoring, but don't withhold that since this diabetes will go up, I withhold my steroids or I'll give less. Less will never work. The best chance is the first chance, and it has to be enough. Pharmacological dose of keeping it enough. Can be divided, counseling can be done, diabetologist can be involved,
Absolutely.
and sugars can be managed. Controlling the sugars will eventually be the child's play. So never withhold the steroid dose for diabetes.
Okay.
Then you have to give a first dose. The first 3 days are the most important. If patient does not improve on a serial audiogram at all, at that time you can think of withdrawing the steroid or reducing the steroid. But steroid should be full-fledged. And also, we don't know what is the primary etiology to this. And if it is virus, there is no harm giving a vasodilator also. So complemental drip along with steroid also is not a bad idea. I mean, you should try your best to give.
Give a chance, absolutely. As Madam correctly said, this is a chance that you are giving to a patient. They have lost one of their important senses, which is very important for their daily routine communication, which can be a big handicap for them in their life. And this is the only possibility for them to recover. And that
And it
will
does
be a
recover,
possibility. It may recover, it may not recover. We have to give full-hearted.
So Bispati, Madam Bispati, the rheumatologist, was a physiologist professor in Naya. And she developed one day in the evening she came. Her husband was told previous night that station to get her hoga, ye hoga. And then whole day she realized that I'm not hearing. We did the audiogram and she had a total loss of the hearing. And then she was a diabetic. So we counseled her, admitted her in this thing for 3 days and used steroid, and she recovered fully.
So that's
And
great.
if you would have been scared of giving her a steroid for diabetes, she wouldn't have recovered. Full recovery she had. So
Yes, Dr. Vicky.
So just one experience where I had a problem with the patient was I got the patient with sudden hearing loss, did the MRI, put him on intravenous methylprednisolone, the patient began to recover. We solved the entire course, covered total therapy, and about 1.5 down, he went a revascular retrospective chemo. It was the only patient which had this problem, and I had a long time, a tough time to make him understand this is an inevitable consequence of steroid therapy.
Yeah.
So what I started doing after that was
10 years not enough.
1.5 years.
The steroid dose which you give for 7 days will never cause relapse.
No, so now there are reports in literature of even steroid creams causing revascular necrosis for a long period of time. This is something which I didn't know, so I started reading about it. And we saw a lot of this post-COVID, people giving 4 milligrams of dexamethasone for 5 days and getting revascular necrosis after a year and a half. So we saw this towards the tail end of the COVID pandemic itself. And that's what made us realize that, now I empirically also counsel them about side effects of steroids, which I was not doing before this because I took it for granted. It's a reasonably safe way to give. I'm a young 43-year-old guy, not even known chap. And now I give empirically vitamin D3 for 12 weeks, once a week. I give Shelcal OS every day for 6 months. A little on the conservative side, I'm a little more worried about because I had one patient who had a problem, but I just want to share this because if we do give steroids, it's no harm in adding some sort of, and this patient had to take biphosphate therapy for 3 years after that.
So basically, when we have these oral steroids going as well, there is a known complication of steroid, what we call as avascular necrosis of head of femur. So we need to be very aware of that, especially in elderly people, perimenopausal or postmenopausal women. In case if they end up coming to you with the sudden sensorineural hearing loss, and you're considering giving them oral steroids, we need to keep them aware of the possibility that they may end up having this, but then with guarded prognosis and well-aware informed consent, I have seen that most of them, they are ready to take the chance because hearing is so important for them. And knowing the fact that that may be a big handicap, they do take this risk. And very rarely this happens, but yes, I agree, such things do give us surprise to take.
We cannot tell the patient that you can develop this complication.
Alright.
Come on, the dose which required and the time which is given is very, very short. And I think this must be one of the rare. And why?
Yeah, that's why,
Why something happening after 1.5 years to correlate with a steroid given for 7 days? I think you have to investigate other reasons of revascular.
Possible. Okay. So basically, let's move on to the next. Yes, sir?
They are taking steroids since so many years.
Yeah.
No increase in symptoms of AVM. Why 7 days they differ? It's a coincidence.
Do you want to answer?
Sorry, I didn't get your question, sir.
Number of selling cases or already ones were there, they keep stay on since years.
Absolutely.
They don't have an entry incident of a year.
Very true, very true. So what happened is, I also was surprised myself, because I think before granting this company, a safe time, 43 or otherwise healthy, quite actively active male. But when I went back to literature, I'm not about Indian literature, I'm not about Western literature, because we don't have much literature in India to corroborate whether we do have a lot of AV and after steroid therapy for routine conditions like this. And they say that even this is what the literature says. I don't know how, maybe anecdotally, maybe incidental, I completely agree with you. But the only added precaution, what I'm trying to say is that we started giving vitamin D and shelter to all these patients for 6 months to be on the safe side. And I went back to his charts. His vitamin D was 6. Now it's just a one-off case. I completely understand.
Yeah.
But we have to learn from mistakes. And if it is a mistake, I would be happy to take responsibility for it. And please, because my other patients don't get the same mistake. So my only reason for bringing this forward was because even post-COVID, we had a lot of literature. Patients had only 5 days of dexamethasone, 4 milligrams twice a day as a post-COVID, second week therapy, which was given to the Delta wave. And we saw towards the tail end. I spoke to, in fact, our transplant, hip replacement colleagues at HN, and they said, yes, we have seen a sudden 2.5 times rise in the number of patients requiring total hip replacement in the age group between 40 and 60. That's when I thought, okay, maybe it could be a correlation. The only I had to propose this to this forum was that I had a bad experience. I just wanted you to learn from it. If somebody can learn from it, I'm more than happy. That's the only reason. And I may be wrong. I mean, in all fairness.
What is the sudden loss normal patient and not
Sudden loss would be at a conductive loss, would not be the
It's a
emergency.
virus, basically, it's virus.
No, but that's where the investigation
not
has
So sudden loss, best thing is just to be on the safe side, do an audiometry. If it's a neural loss, it becomes an absolute emergency. It's a conductive loss, it's a relative emergency, when medications are usually sufficient. But if you get an audiogram of a neural loss, it has to be on the wall.
So, just to summarize quickly, this is one of the ENT emergencies apart from bleeding noses and airway. So you can imagine how we treat this patient in terms of prioritizing. So we have patient who is coming to us with the sudden sensory neural hearing loss. We make sure that audiogram is done on that day itself within few minutes time when patient arrives, so that we get to see the patient immediately after that. We can prioritize their treatment plan. Not only that, otoscopic examination before getting audiogram is very important, because we may be missing out on some findings in front of the eardrum, which are underestimated at times, and then directly patient goes for audiogram. So I would really urge people to make sure that otoscopic examination is carried out before we send this patient to the audiometry. This is how typical sensory neural hearing loss on one side would look. You can see the nerve being weak on that side, whereas after the treatment, you can see how they've recovered. So this is very, 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 what you call for a rewarding situation for the entire team to see that the patient has recovered with the timely intervention.
Yes, many autoimmune disorders are in rise because of poor lifestyle. This is one of the autoimmune disorders. So we are seeing a little bit more of this in this group.
Yes, the Bachi, next question is going to be for you. So be ready. Okay, so we've got 33-year-old housewife coming to us with the complaints of right ear pain and decreased hearing after she accidentally traumatized her eardrum with the use of cotton bud. How would you like to take this further?
So before I deal with this question, my request to every person in this auditorium is that not only for yourself and your family members, but also for your patients, advise them never to use earbuds in the ear canal. You can use the earbud in the outside portion of your ear, but not in your ear canal. Like what I explained to my patients is this. Your ear canal is this, and this is your earbud. How can you clean wax from your ear canal if you do this? You are pushing it into the ear and onto the eardrum. So what happens is that the wax gets hardened, it hurts you, you can hurt the skin of the ear canal is very delicate. So you can hurt your ear canal skin, causing abrasion, probably that's what must have happened. Over here you can actually see a perforation that has been created because of the use of the earbud, which is very possible. Commonly seen, people use matchsticks, people use hairpins, All these should be avoided. God has made our ear in such a way that it self-cleanses itself. Many a times, the ear canal may be slightly narrow, slightly more crooked as compared to normal. Wax may accumulate. Wax also accumulates in young children and sports persons because basically you have more sweating and there is a collection of sweat with a mixture of your cerebrous fluids and your dust that is there. So in such cases, you come to your doctor and get your wax removed, but do not try to do it on your own. Now, when you have already resulted in this kind of a problem, this is a traumatic perforation, most traumatic perforation, most, not all, but most of them will heal on their own. The only thing that the patient needs to be careful is not to put anything further into the ear, keep her ear dry, and get an audiometry done initially so that you know that the patient had a hearing loss. It should not happen that the patient later on blames you for a hearing loss that could have occurred because of her trauma. You get a baseline audiometry done, tell the patient to follow up with antibiotics, antihistaminics, and maybe ear drops, which would be antibiotic with steroid to a certain extent, and follow up every 15 days or every 3 weeks. Most cases can heal by the time 6 weeks pass because this is a huge perforation.
What was the size
So-
of the perforation? The chances of healing is.
So if the perforation is small, the chances of healing are 100%. Small meaning 1 point. Okay,
So
so
if it is more than 30%, it is less likely to be.
the
So-
larger it is, the less likely.
So basically, to conclude this,
Anyway,
Anyway, yes, in the ear.
so conclude this part. Sorry?
Generally, if it is more than 30%, at the end of 1 week of keeping it dry using ear drops, antibiotics, if it is large, like there's a loss of tissue on the drum, it require a replacement.
So just a small request.
Shape of the healing is affect, I mean, the vertical or round.
So basically, both the margin of the perforation is closed, it will like to heal it. But if it is round, then you know, such a large perforation to heal becomes difficult.
Like what we saw with the
Yeah.
last one. that is-
Show up pictures.
The small one is,
See, the lower ones which are there are likely to heal.
the middle one may be unlikely.
So it is this particular diagram is sequential otoscopic examination of the same person. So this particular diagram is sequential otoscopic examination of the same person in a periodic like 2 to 3 weeks time. So starting from that size to this completely healed perforation. So this particular clinical condition, I would say your prescription for this person is no prescription. Do not give any ear drops, do not give any medicines. Just make sure that you treat cold immediately. Make sure that no ear drops are instilled. Do not put oil, ghee, nothing of that sort. Tel, kadi, pani, nothing in that ear. Just treat that ear as a complete sort of, a pristine, clean situation, not to get in touch with anything, and more likely it's going to heal on its own. Yes, sir?
In this reference, today there are so many roadside ENT surgeons are available under the tree and they clean your ears.
Right, sir.
It is very frequent.
Yes.
I want to know how dangerous or how safe it is.
They
Because
should
for
be
few
taken
rupees,
by the police and put it behind the bar.
pardon?
They should be taken by the police and put it behind the bar.
No, madam.
Yeah, believe
So-
me.
That is not at all safe. Answer to your question is, sir. So you've seen the actual images and the otoscopic findings so far we've been showing on different slides. And all this work is done under very precise microscopic vision, which I would say should not be taken away by sort of, that credit should not be taken away from that kind of an effort that goes in.
Just want to add one point, so to your question, you can see this population is reasonably large. What we have to understand is that there is no underlying eustachian tube problem, this is a clean wound. So most clean wounds heal by themselves, like what Mira said, when left untouched. So like masterly inactivity would be the only treatment. But even large ones do tend to heal sometimes because under which problem, the mucosa is normal, eustachian tube is normal. So if you keep the patient cold free, you can give them the best chance of recovery. To understand which population is going to be not going to heal, the best way to do is wait for 6 weeks. In any case, so you wait for 6 weeks, whatever heals, then the pain will be there. It's a trauma.
injection that would be
So
helpful?
anti-inflammatory, if you have some, if you're worried about infection, if it's traumatic, then heart say कुछ अंदर, you give course of antibiotics, even tetanus injection also to be on the safe side. That you would do, but it's basically no local treatment and no instrumentation till you wait for 6 weeks. And
Absolutely.
you have to understand which population will get it, not heal. Instead of giving to conjecture, just wait for 6 weeks. Either which ways, what stays back 6 weeks, you operate. Otherwise,
Absolutely. Next question will be going to Kani sir, and shortly he'll be leaving because he's got some important event planned for the next hour's time. So, sir, next question to you. 50-year-old businessman came with history of diabetes and hypertension, who complains of decreased hearing and ringing sensation in his ears since last 2 years. He never got any testing done, but he's firm believer that his hearing has gone down since then. You do clinical examination at PK and get the following findings. What would you do in this situation where you have got normal otoscopic examination and hearing by and large is within normal limits?
I think this is the situation for observation. I mean, just active observation. Telling them that, look, you're 50 years old, you've got conditions like diabetes and hypertension that normally lead to vascular issue.
Right.
You might be heading towards presbycusis, that is old age-related hearing loss. I mean, today 30-year-old patients are getting cataracts. So 50-year-old patients having early hearing loss. Typically, hearing loss in the beginning presents a little bit of blocking. And that's what this gentleman's coming to. I think this patient just needs reassurance. Hearing aids are not likely to help it. You may give some treatment if you so feel like. In my mind, giving vitamins, giving vasodilators, this, that is all useless. It really helps the pharma companies, doesn't help you, doesn't help anybody. But, I mean, checking B12, checking B3, checking all those kind of things is worth doing. And figuring out if there is any intercurrent systemic issues. I mean, he may have some creatinine issues, he may have some other issues. Thyroid, for example, 50-year-old patient with thyroid can have these kind of issues. So this is the situation for observation. Every 6 months, every 1 year, I mean, you decide what the patient wants. When the patient has trouble in his work environment, in his social environment, then that's when he comes.
So the Bluetooth they are using, that's the microwave, so that was perfect.
Yeah.
I think
See,
many
there-
particularly also.
Basically, those are you constantly using Bluetooth or earplugs or listening music and all that. Eventually, it will cause damage. Even your mobile phone constantly like this.
The microwave.
Now there is a proof that these patients are developing even brain tumors also. So basically, anything which is for a very long time and every day, you should discourage the patient to do that.
We have that question coming up shortly. So for the tinnitus, sir, you would like to give any message before you leave? I understand you need to leave on time. So would you like to give tinnitus?
I think tinnitus is part of the story. Tinnitus means that the nerve is a little weaker, it's getting injured. So treating tinnitus is extremely, there are 500 methods of treating tinnitus, none of which are really good. And the worst thing you could do is to give benzodiazepines, Restil, that kind of thing to these patients, because then you end up getting memory issues, cognitive issues and such things. Of course, if they interfere with your sleep, the patient needs some sleeping care. But this is the place for meditation, yoga, alternative biofeedback, all those alternative forms of therapy. And counseling is probably the most important.
Thank you so much,
Thank you very
sir.
much. Thank you.
And thank you so much. Thanks for sparing your time on Sunday morning and being with us. Appreciate it. Thank you. So we'll go ahead with the next case discussion here. So 60-year-old male coming with complaints of right ear blockage and decreased hearing. How would you like to go ahead, Dr. Anantha, with when person is showing that kind of a vasculation behavior?
So if the patient comes to me with the wax, I would see what is the consistency of the wax. It's absolutely stony, hard, impacted. Then it is best not to be removed at that sitting, because then even if you are able to remove, it will cause, it may cause trauma. Second, while you are removing that wax, the edges of the wax may be very sharp and that may traumatize the extra-aortic canal. So if the patient has pain, you would like to give some anti-inflammatory. If the patient has used earbuds and calls otitis externa, you would also again would like to give some antibiotics, decrease the edema and the inflammation in extra-aortic canal. That will help for the wax removal later on, and also it gives wax softeners. So call the patient a week later after his, so that it's easier for the removal of the wax once the wax is softened and his external aortic canal is, devoid of any inflammation and edema. If the wax is soft enough and it's removable, there are different ways of removal of wax. Under your headlight control, it is easier. It's always advisable to use your headlight and proper illumination and instrumentation to remove the wax. I prefer to use, if the wax is soft, I prefer to use the suction for removal, so that gives you an absolute atraumatic removal of wax with the suction and under direct vision. You can also use, if it is a little less soft and it's like a block, you can remove with a wax disc or a scoop. Yes, you can use ear syringing. Only thing you have to ensure, one is that you are doing a proper syringing, that is, you are directing the jet spray to the posterior canal wall and not directing absolutely against the lining of the tympanic membrane. Second, you have to ensure that once entire wax is removed, you have to see to it that you dry up the extra-aortic canal, because after that, when you are moistening and putting water, instilling water into the extra-aortic canal, patient may develop fungal infection or automycosis after that wax and in the ear syringing. So you have to ensure that you dry up the extra-aortic canal completely, so that the patient does not have any post-procedure complications.
Dr. Bachi, would you like to conclude this particular wax thing, because you were sharing very interesting experience with me only a couple of days back.
So most patients again try to remove wax with a yogurt. You have to dissuade them because they will worsen the condition and not improve. The other thing, as Dr. Anagha has said, there are many ways of removal of wax, and it's very important. Syringing is very good in the right hands. Many a times I have seen people syringing without a headlight, without even visualizing, thinking if I just put pani dalega or wax bar, sometimes patient may collapse because of a vasovagal. So you need to do it under vision, you need to do it with sterile water under sterile conditions. Yeah, and ensure that the wax is out. Once you use a syringe, you definitely need to keep the ear dry. Every patient after wax removal, I always give them 3 days of antibiotics with anti-inflammatory agents and a ear drop, an antibiotic ear drop. And many a times they come and ask me how to prevent this from happening. So then what I advise is that you can put Solivax or Waxol, whatever you want. Put 3 drops every second Sunday or every 4th Sunday in your ears, and this will not form, because the wax, when it forms initially, is going to be very minimal. But otherwise, what Dr. Anagha said, it covers the entire.
Thank you so much, Dr. Bachi. The next one to you, Dr. Jyoti ma'am. Okay, so we have a 24-year-old boy, a guy, attending a music concert where he was exposed to loud rock music, and the next morning he came to us with the feeling of blocked ears. He was evaluated in our OPD with normal otoscopy, everything was fine, eardrums intact, nothing significant happening there. Audiogram did show mild sensory neural hearing loss. What would you advise this?
See, it's very difficult to say that the 24-year-old went for one session of a party and let's say this is the order. I will not completely say that this is because of that, but at the same time, this loss at 4K, which is like at about 45 decibel, is a typical noise-induced hearing loss. So you have to really ascertain the history, that is he doing this repeatedly, is he using this Bluetooth and the phone, how many hours he's on phone, and whether he is living in a very noisy atmosphere or whether wherever he's staying there is too much of a noise of the traffic, the noise of buses and taxis and trains. Probably he has developed this hearing loss of at high K, at 4K, which is noise induced, of course. So there is no immediate treatment like steroids or something. True, but definitely you have to guard him that he has to be keeping himself away from the noises and especially self-indulgence and earbuds and loud music and everything. And probably just to say that he has come one day after this episode, probably will repeat this audiogram within a week's time. So if this was a temporary threshold, probably you may get this hearing loss going back to normal.
Absolutely.
And if it was a temporary hearing loss, temporary threshold of hearing and shift of hearing, sorry. So don't jump into anything that this is for the previous day party. You know, all this is what I said. Repeat this audiogram within 3 to 4 days again and see whether it gets back to normal. It remains like this. Probably he could be having this audiogram for quite some time, even though he's young, because they start off with a noisy thing very early in their lives. So basically counseling, a repeat audiogram, check whether it is becoming normal or it remains here, guarding him with all the advices not to misuse, otherwise because he has developed the loss on both the ears. And probably he will become a candidate for hearing aid shortly, so probably we can allow him little bit. But his speech frequencies are almost near normal.
Absolutely.
So he is definitely a candidate for serial audiograms.
Absolutely. So as we discussed right now, this particular tendency of hearing going down temporarily on sensory neural grounds is called as a temporary shift. What we call as so basically temporary shift, which gets threshold shift and which gets corrected within next few days time. And exactly that's what happened. This guy came back in 3 days time saying that my hearing is back to normal is what I feel. We got his audiogram done and his hearing had bounced back to its normal threshold. So the big take-home message from this particular case is, as exactly Madam pointed out, one has to be very careful of their noise exposure. How long one can have, what precautions are to be taken will be covered in the next slide. You want to add something here? Yeah.
Eliminating the cold drinks, smoking, and drugs or other is the chemical foods.
Yes, but that so we cannot just generalize that.
They hide. No? They hide.
We don't, so probably more susceptibility, what you mean to say. So that, sir, what you call for it is this temporary threshold shift is a very classic thing where you don't really need to treat with anything. It automatically gets better, but these people are susceptible for the tendency of hearing loss. They should be aware of their exposures is the take-home message from this
Stapedius
case.
tendon, which is that small bone which Nita showed in stapediectomy. There is stapedius tendon. So if the noise is above 120 decibels, the God has given a mechanism where the stapedius tendon contracts and prevents the sound going into the inner ear. And but if this is happening repeatedly, then the system fails and you may develop a temporary shift like this. But by giving a rest, no noise and nothing, no medication also, the shift may return.
Right. So let's move on to the next interesting case here. Right. So a factory worker who comes to ENT clinic with complaints of hearing loss, which has gradually progressed to achieve this audiogram in past few years. Dr. Vicky, would you like to brief us on that?
Yeah, so this is what is called as noise-induced hearing loss, and this is actually, it is certified under Workmen's Compensation Act also. And most, at least government settings have guidelines as regards duration of exposure and degree of exposure. I know in our country it's not very stringently followed. It should be, but it's not. And we have a lot of patients coming to us with this similar complaints, especially in a lower demographic where it becomes a question of survival versus job. You know, that's a harsh reality, but what the guidelines say is that 85 decibels exposure for 8 hours a day, cumulatively every single day, is anything above that can lead to permanent noise-induced hearing loss. And those people are one, liable for compensation, and if they do develop a hearing loss, they are mandatorily required to shift their jobs. You know, So of course, most people, I mean, most production units are now mindful about protection. Sometimes it's the patient themselves who are being lax about their protection. But what we can do is, of course, understand what demographic they're coming from and give them an adequate counseling. And now it's time when you've got documented hearing loss to kind of consider a shift of profile, work profile. That's the only way you can prevent a permanent hearing loss. In fact, cutting to the previous slide, even people who have young kids who have temporary threshold shift, which recovers within 24 to 48 hours, 1 out of 5, that's 20% of them will have some hearing problem at a later age. And if they have repeated exposures, they go into permanent hearing loss. That's also the data. So although you may have got scot-free with the first episode symptomatically, your ear damage has already started. And that is why we are advocating now very strongly, with the purpose of World Hearing Day to understand that noise-induced hearing loss is now become a reality, especially post-pandemic, where earphones and inserts became a way of life.
Absolutely. So next question to Dr. Vicky. So whatever patients nowadays we are seeing, and we are telling them to follow some criteria like use only 60% of the total volume for
Yes.
60 minutes. That's the
The 60-60 rule, yeah.
60 to 60 rule. That's all you are permitted for 1 week. Anything you go above, you're going to get a temporary threshold shift. So you may have having temporary hearing loss, and then you have to come back. So I'm going to cover all this.
That's WHO
You're going to
recommendation.
cover that in the talk, right? You're going to cover that. Okay. So now, next part of this question is to Dr. Bachi. The use of headphones and the earpods has increased tremendously since the COVID era, especially work from home culture has started. So what are the guidelines, or what would you like to give message to people so that they can share with their patients? I'm sure people must be coming to you and asking, how do I take care of things? And so would you like to comment on that?
So this is a problem that is commonly seen in the younger age group, the working age group, and these are the ones that are most at risk to eventually develop an irreversible hearing loss. The only thing that you can talk to them about is, I in fact counsel them, is that use speaker. You can talk for as long as you want, but use a speaker phone. Even on your laptop, don't use a headphone. Some people feel headphone is better than the earphone, but no, they are equally bad. Secondly, when we listen to music, the enjoyment of listening to music slightly loud using earphones or headphones is very different. Everyone enjoys using that. You dissuade them from doing this. And you can use your laptop for as long as you want, because they are on a job. You can't tell them that don't do the job or stop after 6 hours. So you let them do it, but preferably use a speaker and you will not have any problem.
Thank you so much for that. So, yeah, sure.
So what generally happens when you're going to a very noisy environment like discotheque something, so patient not only loses his hearing, temporary threshold shifts, but also will lose his voice. Patients do come with hoarseness of voice, because what happens in a noisy environment is that people tend to speak louder over the background noise, and that affects their voice, and they do come with hoarseness of voice once there, and that tends, the temporary threshold shift may recover, but the voice may, they may develop fruitful polyps or nodules because of the constant use of their voice against background noise.
Thank you for that. I think this is the last particular question that we have here. So 40-year-old male was started on multi-drug resistant tuberculosis regime, which I think it may not be multi-drug resistant. This is the actual patient I'm using that term, but it could be any patient who started on anti-COX medication, especially multi-drug, because one of the drug could be ototoxic. So diagnosed with COX disease, soon developed hearing loss in both ears after 2 months. There is no prior history of any ear infection, trauma, or any family history. Would you label this as ototoxicity?
Yes.
Doctor? Yeah, Dr. Bhaji?
If you know the drugs, then probably if they do the streptomycin, definitely it is ototoxic. They are less, other drugs are less likely to cause. So if it was a multi-drug resistance and it was an injectable streptomycin.
And also kanamycin for that matter, which is used as
So this two antibiotic in injectable form can definitely cause.
Yeah. And is there any particular precaution, or is there any take-home message for this particular?
So every patient of tuberculosis that we initially used to treat these patients. Now you have to send them to the RLDP center per se, but the request would be to tell the patient to come back to us and tell us what drugs have been given. Don't walk away from there. You know, because the patient is eventually referred by us. When you know that the drugs are started, whatever the drugs, you can get a baseline automatically done. Tell the patient after 3 weeks, please repeat another one. If there is any change, immediately you can contact the center that you change one of the drugs, which is orthodoxy. So that would help definitely.
Thank you so much for that. So, closing session, I would like to just, we will have question answers, don't worry. So basically, I would like to ask you all esteemed panelists, would you like to share any particular COVID experience related hearing loss that we have not covered so far, or would you like to quickly one by one you sort of, brief? Dr. Vicky, you can start.
So we've seen in the COVID pandemic, idiopathic hearing loss, idiopathic vertigo. We've seen, unexplained post-COVID sitting, even facial paralysis for that matter, all three related to the ear basically. And of course, they are treated like a regular viral infection is treated, because most of our treatments for these conditions was like a viral infection with antivirals and steroids for the most part. Of course, very much understanding that the COVID virus is not responsive to the standard antivirals available in the market today. So in the post-COVID setting, we only changed, we stopped using antivirals, at least in the first wave, second wave. Now, because people are vaccinated and there's lots of other viruses in the air, like influenza, adeno, H3N2, etc. So now we again changed that strategy back to using antivirals along with steroids in this post-COVID setting. But idiopathic vertigo also was.
Yes.
Idiopathic labyrinthitis, it was, we see a lot of it in the end of second year, starting of the third year time, basically. Omicron phase time.
Yeah, we did see these interesting cases
Yeah.
actually during that time.
And it was very safe for us to label them post-COVID, to be honest, because it was more of a diagnosis of exclusion, because we couldn't find any other cause. But if it hadn't been for the pandemic, we would call it as viral. So, sometimes we also do shoot in the dark.
Thank you for that, Dr. Jyoti. Would you like to add something? Good. Thank you so much. Dr. Bachi? Dr. Anand, would you like to add something about this? So I think then we can close the panel discussion for the case presentation part, and we open the question answer thing for the crowd if people have any questions. Mike.
First of all, let me compliment and congratulate all the speakers and participants. You have cleared a lot of doubts. Now, I have two questions. First one is regarding the cochlear transplant. You are putting an instrument. What is the half-life? Is it 10 years, 20 years, 50 years?
So there is.
Number one, let me complete this question.
Okay.
Is there any ISI mark? Is there any particular brand you use? Or I would like to know, because it can be for 20 years, 30 years, 40 years. And question number two, there are a lot of people who do traveling, air traveling. So what are your maybe advice or for the do's and don'ts? Because there's sort of change in air pressure and all that could lead to hearing problems. You have two questions.
Okay, so for the second question which you asked, basically, if you have got a cold or for traveling, but if you have to travel, then you have to decongest some tablets before the flight and 3 hours before the landing on the flight. So,
Any local thing like club or anything or cotton swab?
no.
Okay.
Because it is within each station too, from inside out, it is not outside in. But cotton, if you are finding the AC of the airplane too heavy and all that, if you want to put a cotton, it's fine.
No, this
That's
question,
But that will not prevent your barotrauma.
question is related to hearing, not to the air.
Same thing, hearing, barotrauma only leads to hearing loss. Barotrauma only leads to hearing loss. So decongestion tablets, nasal drops, and keeping your institution tube as healthy as possible is the way to prevent. You can still develop though, but it is way to prevent the hearing.
I'll answer the first question, sir. So the oldest cochlear implant is more than 40 years old, which was implanted, and the indwelling device is still functional. The reason for mentioning is that the cochlear implant is a lifelong insertion. It is inserted in a sterile environment, and till now, of course, technology is only about 40-50 years old. So we do understand that there may be something which will come out 20-30 years, which will show that these can be extruded. But so far, we have not had an experience about exclusion of the internal implant. The second part, which Dr. Bachir pointed out, the external part of the implant needs to be changed periodically. Once in a few years, maybe 7 to 10 years, की life रहती है उसकी. But for the most part, the inserted part is for life. And even the old generation implants, which are not, with the current technologies, multi-channel, slim electrodes, barely visible as a bump above the scalp. The older ones, which are much more bulky, are still surviving in the cochlea today. So,
I mean, there are few, as we all will agree, at the end of the day, it's a foreign body that is kept inside. Some people do develop some unrealistic kind of reactions that happen, and then they end up having repeat surgery where we have to take out the implant, wait for a time, then go on the other. So these things do happen, but they're very rare. You don't encounter these things very commonly and routinely in your practice. Dr. Bachi would like to share something.
One thing that we all understand as surgeons is that the implant is very expensive. So all of us are very aware, and we check the implant. Not only is the implant checked by the factory, but also intra-surgery. Before we close the implant, also it is checked. And after that, the patient can keep the implant throughout his life, at least for the next 40 years for sure, because that is what we have seen. And we assume because it's a titanium implant, so probably it would stay lifelong. In the very rare event of any infection or something, we need to remove it and then you will replace it also. It's not that you cannot replace that. But the external processor is so nice that you can keep changing it. Supposing the patient is not very affordable, you can use an external processor which is not too expensive. After 3 or 4 years, you can change it with the same internal device. You can change the external processor to a higher external processor.
Yes, sir.
I've got one case of sensory neuronal loss. He's about 40-year-old, super executive. He's managing everything.
Right.
Somebody has advised some special spectacle which can be put inside or outside.
Yes.
Whether it will help.
So that's not a cross hearing aid. It may help. I mean, not many patients are happy with it, but then always remember, whenever you are asking for a hearing aid, ask the audiologist who is dispensing the hearing aid to you. Firstly, do not buy it off the counter. I have had patients who have come to me with a hearing aid, Dubai se lekar aaya. My son sent it. It is not like that. You have to have an audiogram. The audiologist is the right person who will guide you as to which hearing aid will suit your hearing loss the best. And once you decide that, you take it home for a trial for at least 7 to 10 days. Because in this kind of an environment, you will always hear well. When you are at home, you have the TV running in one place, noisy environment outside, or when you are in the marketplace, it is at that time that you should be able to hear well. So many a times, I explain to the patient, it is not like spectacles. That you can just wear it and you are fine. Once you wear it, you go home, you realize you are not fine. I cannot hear. I am hearing the noise of the fan much more than the voice of my wife. You come back and talk to the audiologist, they will again change the settings. So today we have excellent computerized hearing aids, but we need to reset with the optimal result, and it could take 3 to 4 sessions. That is very important. And regarding unilateral hearing loss, I will tell you one of my friends who is a consultant right now in the ICU, not in this hospital, in another hospital. She has studied with me. She has a unilateral hearing loss. She even uses a stethoscope and there is no problem. So it depends from person to person. Usually people don't even realize that they have a unilateral hearing loss. Many of them. So actually, you're mentioning is the bone conduction hearing aid. So that spectacle would be the bone conduction hearing aid. So there's nothing going in the over the external auditory canal, but it is the bone conduction hearing aid.
And as Dr. Bachi clearly pointed out, I totally agree with the unilateral hearing loss was a lot of time undetected. In olden days, it has come up, it has resurfaced, or we got to surface only after invention of phone, because you can compare which ear you can hear better, from the extent that people say I can hear better from this side than the other. We never had phones before, and that was probably underdiagnosed in the past, I guess. Anyways, we would then.
I have a very nice.
Whether CT or MRI help in operating or not.
Plain X-ray.
Plain X-ray.
Plain X-ray radiotherapy. Lateral.
Yes, sir. Can someone give him mic, please?
What is the role of this combination of teardrops, the red teardrops, photo is the
madam told not to use earbud, but some patient are feeling itchy sensation.
Yes.
They feel very pleasant and enjoys the place.
So it's a vicious cycle, I would like to tell you, sir. What happens is that your skin actually is reacting to every kind of a stroke that you are giving with cotton bud. It becomes more like a vicious cycle that skin never remains same because you are actually scratching it all the time. If you continue to scratch your hand from one side and not on the other, you'll realize how that skin feels or becomes over a period of time. That's what you're doing inside where it's not even visible. That too with the sweat, humidity, the dry skin and shedding of the little bit of a wax collecting there, entire process becomes more like a sort of, a vicious cycle where normal cleaning mechanism fails because your normal skin is not there. I think Dr. Bachi did mention how actually you end up making it worse for the normal ear to clean when you're using your cotton bud. So you're not only you're causing harm to the local skin, potential damage to the eardrum. In addition to that, you're putting local skin at a kind of a dermatitis kind of a situation, which will not function normally thereon, and normal cleaning mechanism will fail.
Autolysic eardrop.
No, listen, in that situation, if it is only plain itching and then that triggers that I want to put something in my ear and scratch, plain wetness all eardrops are okay. Plain wetness all eardrops. And avoid, you have to discourage them from putting anything in the ear. That other combination antibiotics drops are not advisable.
I have a few queries to our esteemed panelists. I would like to know the difference between the tympanoplasty and myrinoplasty first. Second one, in which patients and when do you recommend PTA? Third one is, as ma'am said, already explained the information of complications of CSOM. So I would like to know how do you clinically document whether it is safe or unsafe CSOM?
So you are a general practitioner?
No, I am preparing for the PG.
No, but you have to know how to see the ear otoscopically. If the perforation is in the pars tensa, it is safe ear. If the perforation is in pars flaccida, that is in attic, it is unsafe ear. Also, if the polyp or perforation is the posterior superior quadrant, it is unsafe ear. So you have to master otoscopy to differentiate at your level whether it is safe or unsafe. If the patient has presented with some complication like facial nerve paralysis or severe tinnitus, hearing loss, or meningitis symptoms like having a fever, neck rigidity, or convulsions, or brain abscess signs, then it is evident. But if patient walks into your clinic and you want to know whether it is safe or unsafe, you have to master otoscopy. There is no other way. CT scan or MRI and everything comes later, and it is not done routinely in every patient of unsafe. If he has some sign of complication, then only you do CT scan to rule out brain abscess. So basically, it is otoscopy, and they are going to, I think, demonstrate and teach you how to do otoscopy findings. So you have to master otoscopy.
This is the most common complication we routinely encounter, and how frequently we need to assess the complication. Is it an abscess or most common complication?
The post-neural abscess is the most common. Subperiosteal abscess in the mastoid area. There are 5 types, but we just remember one which triggers to other areas. So abscess externally is the most common. Similarly, abscess in the brain also is possible. They has eroded the disease and meningitis. But that is not like, instantly patient will come. There will be some lingering sign, headache, fever, projectile vomiting, which he could have neglected, and now he has landed up with a brain abscess. That will be only diagnosed on the severity of the patient's symptoms and the CT scan. So the commonest is abscess and patient of paralysis.
Thank you, ma'am, for that. Thank you so much for
In which patients do you recommend PTA? And
every patient PTA.
Okay.
Excuse me.
Sir, yes, sir.
Is age-related deafness a reality or a myth?
Reality.
And secondly, if you are living in a place where it is very noisy all throughout, say for example, I stay near Chariot station and on the main road. So it is the traffic, it is the and it is the railway estate nuisance, and there is a wedding place opposite. So now, what is the preventive type of thing which I can advise my neighbors to use so that their hearing loss is minimized over the years? Preventive.
So ideally, you have to leave the noisy place and go, which is not possible.
It is
I mean,
not
you know,
possible.
So then basically using a earmuffs, protective earmuffs, which are industrial workers are also asked to use, that you can use and avoid any noise which you are creating in your ears by mobiles and Bluetooth or a large TV volume or whatever, you have to avoid. It is basically prevention, you can't do much.
Yeah, this is a social problem. And it was originally told that whole Bombay is a silent zone, but where is that? Who is giving effect to that type of announcements? You see, and even the silent zones have been so noisy that this is one, I think the ENT surgeons and your community can go after the government and tell them to implement silent zones and other safer devices.
Sir, we are doing it, no honking with rickshaws and taxis. Dr. Samir Bhargava, who is a Rotarian also, and he was the AOI president. I think during his tenure, there was maximally done to educate our rickshaw and car honkers also. How much they honk. They can see there's a traffic jam, they can see the red signal, but still they are honking.
And
So all that is being done.
even the motorbikes, earlier, that they were not so noisy, you see, and because of the law, and they were implementing that law by punishing these people. But now you see, almost every minute there is a motorbike which makes such a huge noise on the road. So this is very important for the whole society and whole community, that otherwise after 30-40 years you will have the deafness in almost 70 to 80% of the population. Sorry.
That's very true, sir. And I would like to conclude this panel discussion on the same note what you raised the issue in terms of social problem. We are talking about honking of the people on rickshaw and motor cars and all. But what about us people, educated, and when we are aware of the fact, paying money for the movie tickets and sitting in the cinema where we are getting exposed to so much of loud noise? What are we doing then? Have we thought about it? It's a very important point that you all need to consider. Make your patients aware of this fact that you're paying for your hearing loss. You're paying for your hearing loss to get yourself one or two frequencies fired with every loud music where you have disco parties or you have there is Sangeet happening and all that. Who will regulate that? We host such parties. Can we be owners of our own hearing now?
Why not ban such parties where loud music is played? Sir, there are lots of things that we can do as the doctors and advise the government and force them to implement. You see? And another thing is about the honking. Even I myself feel guilty of that. You see, my son's children who were born in Canada and come on a visit, after sitting in my car for some time, they taunted me. Kaka, how much horn you are playing? In Canada and USA, they never hear a horn. If it is a horn being played, then there is some insult to the driver.
Absolutely.
Around.
So it is exactly like how cigarette smoking is bad. Although people are smoking, we know that loud noises are bad, but we are not doing much about it. I think it is individuals' responsibility. None of the associations can do anything for that unless and until we work for that as individuals.
The mobilization of the public opinions, madam.
Thank you so much for this particular good panel discussion, esteemed panelists. I really appreciate you all taking Sunday morning time out, and we will be talking about different hearing tests. So Priya is going to quickly run through with the different hearing tests and their details. Priya, can I call you?
I would like to, on behalf of the panelists, I would like to thank you for the excellent session that you conducted. And
thank you so much.
I almost all the
If you guys have the great, you want to stay back, please stay back.
Okay, so good afternoon, everyone. It's almost 12 noon. So I just few minutes back, I had a big
Yes, sorry to interrupt. So I'll just quickly do that and then you can.
So basically, once Priya's talk is finished, we've kept some otoscopes so that you people can practice and see how eardrum looks like on each other. So we've kept those otoscopes handy here for you all, okay? So once Priya's talk is done, we can.
So a lot of male population was also there, and I wanted to ask them that how many of them have trouble listening to their wives. So I'm sure many will raise up their hand. So we'll first move on to whoever is there, like if you get a patient and if they, what complaints will they come to you with? Yes, it depends on the distance also. So you will have, the people will come with a complaint of asking for repetition. They have to keep their volume high of the television. They do not follow conversations in noisy environments. They are unable to hear the doorbell, or they find difficulty in listening to their telephone ring, or they often speak loudly. So these are the adult population will mostly come with these complaints to you. What about if you come across some children, like you may have parents who will come telling you that my child doesn't respond to these sounds, or he doesn't respond to a name call, or he doesn't he doesn't speak age appropriately. He may have mispronunciations, and the parents may say that he doesn't speak clearly even though he's 5 years old. He's performing poorly at school. Teachers, school, or parents complain that child has poor attention, does not attend to instructions. They may have discharge from the ear, they may have ear pain, or they may have blocking sensation. So we'll have to keep in mind about all these complaints whenever the patients, parents, or the children come to the clinic. So going ahead, we are first going to cover hearing evaluations. So we'll case history, like we saw, we'll first take the case history, like what is the complaint, then what are the communication difficulties they have, if they've had any ear infection, is there any family history, like in otosclerosis, you may find that it usually runs in the family. You may have progressive hearing losses, which also run in family. So that's why family history is important. You need to know the medical history, and you also need to know if they have any vertigo or tinnitus symptoms. So like how we are going to cover the otoscopic examination in the next session. So I'll not go into these details, but this is how a normal tympanic membrane looks. This is the right side. And that's the left side. And then you have the cone of light. This is the cone of light, the mammograph of Malus, and the long process of Incus. So what are the ways of getting sound to the cochlea? So whatever sound is coming, I'm just going to touch base on some basics so that we will go into the investigation part. We have two ways. One is the air conduction and one is the bone conduction. Air conduction is by the ear. It goes to the ear canal, tympanic membrane, stimulates the ossicles, the main organ of hearing, cochlea, and then goes to the auditory nerve. Bone conduction, you place something on the bone and it directly goes and stimulates the cochlea. So that is the bone conduction. It skips the process, your external ear and the middle ear, your ear canal and the ossicles. So the first most important test, what we do, which is gold standard anywhere in the world, is pure tone audiometry. So pure tone audiometry, you do it from the age range of 3 years to 2.5 to 3 years. You can do, and you can do it in as old patient as it can be. The only thing is you need to, it is conscious hearing. You need to click a button or raise your hand whenever you hear. That's why you cannot do pure tone audiometry in very young children, because they cannot respond. They don't know to respond to sounds. So this is a setup of a pure tone to conduct the test pure tone audiometry. You need a sound treated room. You cannot have a soundproof room, but you at least need to have a sound treated room. And it's a 2-room setup. The clinician, the blue. So this is the clinician. This is the instrument, and this is the patient. So this is the instrument, the headphones, the bone conduction. So a pure tone audiometry has a bone conduction and an air conduction. So headphones and the inserts. You can either use earphones or you can use headphones to conduct air conduction testing. And you will require a mastoid or a bone vibrator to do bone conduction testing. So this is how you change. So normally once you are born, you hear from 20 hertz to 20 kilohertz, 20,000 hertz. And as you do not use those extreme frequencies, because those are the sounds which we do not use, we'll end up using the most common frequencies are 250 hertz to 8 kilohertz. That is the range in which all sounds we hear, and we use that for communication. So that is why an audiometer also tests these 250 hertz to 8,000 hertz frequency. So what is an audiogram? Audiogram is a graphical representation of the test. So like there was a question in the initial time that what is the difference between audiogram and pure tone audiometry? It's the same. Audiogram is the graphical representation and pure tone audiometry is the test name. So this is the intensity level, -10 to 120 is what we can present by the audiometer. And this is the frequency. This is how we test at different frequencies and intensities. A normal hearing is from -10 to 20. So a normal hearing person should have an audiogram anywhere between -10 to 20. Your red circles on an audiogram denote right ear, and the blue crosses denote the left ear. So usually if they are color marked, it is better for identification. So there are different degrees of hearing loss. Normal, like I said, it is till 15. Then you have minimal hearing loss between 15 to 25. Then you have mild, moderate, moderately severe, severe, and profound. So like mild hearing loss will be like this somewhere. This is moderate hearing loss. This is severe hearing loss. Now, what are types of hearing loss? So you have an audiogram where you did your bone conduction, you did your air conduction, but now you want to know whether it is conductive hearing loss or sensory neural. So in conductive hearing loss, there'll be the problem in the ear canal, the tympanic membrane, or the middle ear. In sensory neural hearing loss, there'll be problem with the inner hair cells or the auditory nerve. In mixed hearing loss, all the three may have a problem. So conductive hearing loss, they can be temporary or they can be permanent. It is medically treated either by medication or surgery. There could also be abnormalities of outer and middle ear. So outer ear abnormalities could be absence of pinna. There could be anosia or there could be atrasia, due to which also they have hearing loss. So these hearing losses are congenital in nature. So like a child born with a malformed pinna. So they may also have hearing losses. So there are different causes for conductive. We have covered that, many of them in the panel discussion also. So I'll run through this. So a conductive hearing loss, because your inner ear is normal, your bone conduction thresholds will be normal. So they lie between -10 to 20. Whereas the air conduction, because there is a problem with the eardrum or the middle ear apparatus, there you'll have an AP gap. The air conduction will be low. So causes for sudden sensory neural hearing loss could be
as above. There could be acoustic neuroma or head trauma. There could be ototoxicity. There could be presbyocusis, noise damage. So there are, these are different, so this is one representation where your bone conduction and air conduction thresholds are together, because there's a problem with the main organ of hearing. So your air conduction also gets affected and your bone conduction also gets affected. In mixed hearing loss, your nerve function, your bone conduction can be better, but it's still affected, and your air conduction is more affected. That's why you find slight AB gap, but it is below 20. Your bone conduction, once they go below 20, then your sensory neural component is added. That's why it's called a mixed hearing loss, a combination of conductive and sensory neural. So you may come across such audiograms where you have a sloping hearing loss, you have a rising hearing loss, you have a flat, or you have a unilateral hearing loss. So why I'm covering this all is because an audiogram will require all these characteristics. You need to know the degree, you need to know the type, and you need to know the configuration. And then you will know what exactly is the problem. Other important factors are we need to know whether it's congenital or acquired, bilateral versus unilateral, symmetrical or asymmetrical. So if you find an asymmetrical audiogram, you may have to investigate further as to why is there asymmetry. Because if there is a normal degenerative process, then your both ears degrade together. Whether it's progressive or sudden hearing loss, fluctuating or stable hearing loss. You may find a fluctuating hearing loss in Meniere's disease, patients who have Meniere's disease. This is a typical of noise-induced hearing loss, which we saw in one of the case presentations. So Dr. Vicky was talking about speech banana, that if we do hearing aid fitting or if we do cochlear implant fitting for any adult or children, and they should lie within a spectrum, and that is when we say yes, they are candidates for surgery or not, then this is what they should lie between almost 30 to 60. There is a graph here so that they can hear all the sounds which are normal for their development of speech and speech development. So if they're after wearing hearing aids, and if we do their audiometry, if their audiogram comes in this spectrum between 30 to 50, then they can hear normally. Their speech and language development will become normal. So at that time, you may not be a candidate for cochlear implant. But if they don't lie in this range, and if they lie something here down, then they may be a candidates for cochlear implant, because they are not able to hear normally, even with hearing aids. They are able to hear some sounds, they are not able to hear some sounds. So that is why they have to undergo another intervention, or else they will not develop normal speech and language. They may have misarticulations in their speech and etc. So these are different configurations. You have seen a lot in the panel discussion. So I'm just running through this. This is bilateral symmetrical hearing loss. This is a unilateral hearing loss, mainly seen in patients with Meniere's disease who have vertigo, ringing, blocking sensation, and a hearing loss. This is seen in patients. This is again an symmetrical hearing loss. One ear is normal hearing, the other ear is has a sloping hearing loss. You may see this if you have a vestibular schwannoma or acoustic neuroma, along with other symptoms, not just hearing. This could be, if you see here, the bone conduction is normal and only the air conduction of the right ear has gone down. So this is most likely a conductive hearing loss. So coming back, so this is all about pure tone audiometry, which we do from the age of 3 years to, you can do it, there's no age limit. And you also do other tests like impedance evaluation to test what is the function of the middle ear. So we'll cover that in this, and I'll then come back to children in some time. Yes. So impedance evaluations, you do it to check what is the middle ear status. Is there fluid? Is there a eustachian tube dysfunction? Is it autosclerosis? Or is it ossicular chain discontinuity? So different tympanograms represent different things. So suppose if there is eustachian tube dysfunction, then you may find this kind of a tympanogram where the pressure of your middle ear shifts towards the negative side. So like if you see here, it's almost gone between 200 to 300. If there's fluid filled into the middle ear, then you may get a type B tympanogram where it's almost becomes a flat line. Why does it become? How you do it? You put in a probe in the patient's ear and it has a pressure tube and a sound tube. And you have to just press the button. I forgot to put the image. So you present, it is an automatic test. And what it does is your eardrum moves with the help for that, your eardrum. What this calculates is your eardrum's response to the sound and the pressure. So that these are the curves what we get with that. So if your eardrum doesn't move, if it goes as a flat line, that means there's something filled. If your eardrum is quite retracted, then you may get this kind of a tympanogram. If your eardrum is healthy and nice, you may get an A-type tympanogram. Even in autosclerosis, you may still find an A-type tympanogram. If the ossicular chain discontinuity, that means the bones are moving fast, then you may find an AD type of tympanogram. And if there's fixation of those bones, then because the eardrum mobility is slowed down a little, you may find an AS type. So if you see, this is the compliance of the eardrum. So if this is the normal, this is very low. Here there is hardly any compliance, and here there is very high compliance. So this is a typical case of autosclerosis, where you see that on the right ear is normal, the left ear has hearing loss, left ear has almost moderate conductive hearing loss. And if you see the compliance and the type of tympanogram is AS type, and here it is A type. Then we also have speech audiometry. Like how you do pure tone audiometries, you place headphones, you instruct the patient saying, I'm going to play some tones. Whenever you hear the tones, you have to click a button and then you have to respond to the softest sound, whatever you hear. That is the instruction what is given for a pure tone audiometry. So that you do with the help of tones. For speech audiometry, they have to answer to the words, whatever the clinician says or whatever is tape recorded, and they have to repeat those words. So there could be spondees like 1, 2 or 5, 6, or it could be just monosyllables like cat, bat, man, all that. But all these words it's a standardized test. You can't just use any words. You have to cover all the speech sounds, all the frequencies, and that's how these tests are made. So you do this. Ideally, it should be done with every patient who undergoes pure tone audiometry. Internationally, like they do speech audiometry is included. It's a part of pure tone audiometry. But here we do not follow that. Here we do it for patients who have trouble understanding speech, who do not benefit a lot with the hearing aids, or who have difficulty understanding speech. They can hear well, but they do not understand what is said. So with them, you do speech audiometry. Then you also have tinnitus evaluation. Some patients, so like conductive hearing loss may come with a buzzing tinnitus. Any pathology, conductive pathology may come with a buzzing. You treat it and they may get better. The tinnitus may go away. In sensory neural patients who have sensory neural hearing loss, you may hear a ringing of sound. So ringing, they may hear ringing and it doesn't go whatever you do. So this tinnitus evaluation, we usually do it with patients who have continuous ringing. It is not going, and in them you do tinnitus evaluation. So there are different ways how we do tinnitus evaluation. It is beyond the scope of this talk, so I'll cover that maybe next time. Just coming back to how you do it in children, you have play audiometry, where you place headphones on the child. So this child may be likely of 3, you can do it even in 2.5, depending on the cognition. If they are able to respond, you could do it on them, or minimum age is 3 years. You train them in such a way that the blocks, tell them that, you'll hear a sound from the block, and whenever you hear, you just put that block down, or you could use some rings or anything. And that is how you do an audiometry on them. This is behavioral observation audiometry, where a child, you do it mostly in infants, as young as few days to maybe a year's time or 6 to 8 months, where they can't respond. But you can look at their expressions and understand if they are giving a response or not. Like they may have a suckling on the pacifier, or you may find there was an eye blink, or there was a startle, or they cried. So all these kinds of responses, or they may have some freeze whenever they hear a sound. So all these responses you will find when you do it on very young babies. You cannot do any threshold estimation during this test, but you get an approximate idea whether the child is listening to moderate or mild to moderate sounds or not. Then you have VRA, which is done from 6 months to 2 years. So first you have BOA, which is done when very young individuals, very young babies, 6 months to 2 years, because you can condition them. That's why you have this VRA. In this, what you do is you have to make the child seated on the parent's lap. The sound will be presented from the speakers. You don't place any headphones in this. The speakers will be lying in the front. You will hear the sound, and they'll have a reinforcement. You train them in such a way that if you respond to the sound, I'm going to give you some reinforcement. So the reinforcement will be a light emitting toy. So you give the sound, and the child gives the head turn and looks at the toy, because they are getting a reinforcement. So that is how you train them for doing VRA, and you get responses accordingly. Then you have BERA done. BERA is done for children in whom you cannot do pure tone audiometry, where you can't find responses on thresholds. So as young as 1 month old child, if you want to find out if the child has any hearing loss, you could do this test. This test involves placement of electrodes. The child has to be sleeping. In this, you place electrodes on the child's, there are 3 sites where you place the electrodes. You present sound. There are few protocols which are followed, like you present sound at this level and at this repetition rate and all. And then you get a waveform. This is the waveform. So this is the normal waveform which you obtain at 90 dB decibel sound level. And this is the response what we look for in BERA when we do it in children or anyone. So wave 5 is the most important one. And that is how you track if the child has a hearing loss or doesn't have a hearing loss at different decibel. You do a threshold estimation using those waveforms. Then you have OE. OE is autoacoustic emissions. It is a quick hearing screening tool done on babies, especially used in newborn hearing screening. It is done in many big hospitals. It is also done in clinics and all. And it's a simple test. You have to just put a probe, and the probe gives a sound. And in response, our ear has a tendency to give a response to those whatever sounds it hears. So that sound is picked up by the microphone, and that sound is recorded as a response, and you have two criteria, whether it is pass or refer. That's all. It will not tell you anything else. How much hearing loss, degree, type, nothing. It just tells you whether you are pass on the hearing screening or you are refer on the hearing screening. So if you are pass, then you need to undergo further investigation. But if you are refer, then you will have to undergo further investigation. So we look for high risk factors in all the children who are in NICUs or in Well Baby nursery, and depending on that, we ask them for follow-up. Okay, now I'll do the case presentations, whatever I have, I'll do at the end. I want to talk about this also, since it's World Hearing Day and all should be aware about what are the different noise exposures we are living with, and how much harm are they causing on our body. So like these are concerts where we go sometimes, or some people have a tendency to go once or twice a week. Some of them may go rarely. Use of headphones is, I think it's normal, everyone does it. And how much in a stadium, how much is the sound level, and how much is the sound level in a disco or this. So these are different leisure sounds. So these are the sounds which we don't invite, or we are not doing it on our own. These are sounds which are present around us. So those sounds also tend to cause some hearing impact, some impact on our hearing. So this was a patient, 51-year-old male. I'm going to talk with case studies for this part. He came for health checkup, had no significant ear-related complaints, but he had a slight dip on this 1 kilohertz frequency. Like I said, you should have a symmetrical hearing loss, but why was this only one frequency dip? So when we probed him, he had history of use of mobile phones for work purpose for 7 to 8 hours a day. And that is why, and he was using it on the right side. So just using mobile phone for such a long time gave rise to this kind of hearing loss. So mobile phones give rise, they generate radiation, and that is why you tend to have hearing loss because of that radiation. Again, there was one more individual who had come for audiological evaluation, and he had this dip. We have covered this. So again, he had 4 kilohertz, and it was because of he had used a lot of mobile earphones for a long time. So hearing conservation strategies that we advise is 60 to 60%, which I told before, that if your mobile phone has 15 clicks, you can increase the volume by 15. 60% of that is the recommended level. If you go above that, then you are going to damage your hearing. If you suppose hear that only for a few minutes, it's okay. But if you're going to listen high level sound for more than 60 minutes, it's going to give rise to some temporary threshold shift. If you keep on doing that every day, then it's going to give you a permanent hearing loss. So it's advised to use noise cancellation earphones. So best is landlines if you have to use for conversation, but we are no more in that world of landlines. Then you put it on speakerphones. If that is also not possible to use it on speakerphones, then you use over-the-ear headphones, noise cancellation. If that is all, I mean, that is the last option. But if you don't have that, then you go for AirPods. And if that is also not there, then you go to this, but then this is going to cause, so that is the severity at what you're damaging your ears. Someone asked about Bluetooth, like we are using that, but we are all around energy. Like even Bluetooth energy, like you have Wi-Fi, that is also giving some radiation. So we are surrounded with some or the other radiation around us. So this is going to give some impact on our health, but at least having Bluetooth headphones and instead of holding the phone like this, it's better to use those Bluetooth headphones to at least reduce the harmful radiation from the mobile phone. So if you're going to any noisy surroundings, you should always use earplugs. If you know that that sound is going to be too loud, you can use earplugs. You either get it in any store, you can get it in a store, or you could also make it according to your ear canal size. That is also available. You should stay away from the speaker, from where the loudspeaker is there. Avoid staying near to the loudspeaker, or that will surely give rise to some temporary hearing loss. So coming to the management, this is all about evaluations and what all we are, and the leisure sound or whatever sound is near us. Management, medical and surgical management was discussed in detail. Then you have auditory rehabilitation. So as young as 1 month old or 3 months old, you can fit even a 3-month-old with a hearing aid. If it is proven that he has profound hearing loss or whatever, or it's established that yes, he's not able to hear, you can fit even a 3-month-old with a hearing aid. The Joint Commission of Infant Hearing, they have a protocol of 1:3:6, which got revised. That is 1:3:6 is 1 month. Your hearing screening should be done. By 3 months, your diagnosis that the child has hearing loss needs to be confirmed. And by 6 months, you need to do some management for that hearing loss. The rule has been revised to 1, 2, 3 now. That 1 month hearing screening, 2 months definite diagnosis, and 3 months the management should be done. Like some strategy to rehabilitate the hearing loss should be in place. But of course, awareness takes part in this. Your newborn hearing screenings have to be really good to follow this protocol. In India, we are in today's thing, we hardly are detecting hearing loss way early, because newborn hearing screenings are happening in all larger places, but in rural areas and all, newborn hearing screening, I don't know how much does it happen. So we may land up detecting at 6 months, 1 year, 1.5, 2 years. And the more you delay, the more plasticity of the brain, or the auditory plasticity reduces. The speech and language development, normal speech and language development gets reduced. Because even if you implant at the age of 3 years or 4 years, 5 years, you may not have normal language, like normal pronunciation of speech, or your social, emotional, behavioral development may get a little affected. So you have 2 things. You have either hearing aids or implantable hearing devices. So these are the hearing aids. This is BT hearing aid, which we usually give to patients who have profound hearing losses, severe to profound hearing losses. This is, you can give for patients who have, so every hearing aid has its own criteria. Like you can't give any hearing aid to anyone. You have to know what patient, and मुझे नहीं छोटा ही चाहिए, वो दिखना नहीं चाहिए. We can't do it. It can't go that way. If you have a discharging ear, you cannot go for a very small hearing aid. You're just going to damage the hearing aid by giving that. Plus, you can't give a mild hearing loss or this powerful hearing aid, because he's not going to appreciate the sound quality. So a hearing aid needs to be chosen according to the hearing loss, according to the lifestyle of patient, whether he's homebound or whether he has to go attend court meetings. The difference in the hearing aid lies there. You will not give any hearing aid to any patient. If he is just homebound, he has to just do one-to-one conversation. Even a basic hearing aid will work for that patient. Then you have implantable hearing devices, like we discussed about cochlear implants and BAHA. Cochlear implants, you have an internal component and an external component. An internal component has an electrode array which goes into the cochlea. And then you have an external component, which is the processor, which sits behind the ear. It communicates with the internal component, and that is how the sound is transferred from outside to inside. So that is cochlear implant. This is giving true hearing. Cochlear implant is, you're actually giving true hearing, because you're going inside the cochlea and stimulating the main organ of hearing. In BAHA, you're using the better hearing on the other side. This is not true hearing, but you do this in patients where you have middle ear pathologies, who are not benefiting with hearing aid. Whatever amplification you give, they are not benefiting with hearing aids. That time you do Bahas. You also do Bahas in children who have normal bone conduction thresholds, who have an anosia or a microtia or an atresia, who have abnormalities of the external ear. In those are the children where Baha is recommended, because they'll end up having moderate to moderately severe hearing loss bilaterally, but their inner ear is normal. So you use that normal hearing of the inner ear to get them normal hearing, even by acoustic, by ears. You use a lot of communication strategies, and then there are care of ears, like don't put oil, and all this can be told to the patients. Yes, we have given the leaflets. They are very nice leaflets. I think they are there in your folders. So please go through them. They're very good for primary healthcare workers. And using of communication strategy, even when you're wearing hearing aid, you're not wearing a hearing aid, you have a hearing difficulty, using these strategies really help in better communication. Thank you. Please,
We'll form small groups now where we'll give otoscopes to each one of you, where you can actually get to practice to see how the eardrum is. So Dr. Vinay and Dr. Sundarshan telling me small groups and take one otoscope. They start from behind. The first person can go there, but open people. You can share your otoscope and start.